Good morning, my colleague. Welcome. I am proud to be here today to sharing all of you with one very interesting workshop about advanced neonatologists, the formed echocardiography and male hemodynamic. All of us know that hemodynamic compromise in early neonatal period is common and may lead to unfavorable neurodevelopmental outcome. Understanding of the physiology, the cardiovascular system in neonate, influence of antenatal factor, postnatal adaptation is very essential for management of infant during early critical stage. Impact of various ventilator modalities, EDA, systemic inflammation, all may affect the hemodynamic. Plus poor clinical indicator, systemic perfusion, plus relative insensitivity of conventional echo technique could not provide us as neonatologists with enough information to guide clinical decision making. That's why we start to search about another modalities, how to evaluate the hemodynamic, especially in preterm baby. That's why we go to another road and start to speak about integrated hemodynamic in neonatal care. By integrated hemodynamic in neonatal care, we mean clinical details, we mean target neonatal echo for assessment of cardiac output, extra and endocardial shunts, systemic and pulmonary vascular resistance. Speak about near-infrared spectroscopy for assessment of oxygen delivery and organ oxygen consumption, degree of compensation, and organ-specific ultrasound. We are lucky today because we have three pioneers in hemodynamic: Dr. Yasser from Canada, Dr. Nick from Australia, and Dr. Samir from UK. We want to thank Dr. Abdullah because he's the one who collected all the three pioneers together. Most welcome, Dr. Yasser. We'll start with Dr. Yasser. Dr. Yasser is the Director of Hemodynamic Target Neonatal Echo and Point of Care Program, Assistant Professor, Pediatric, University of Manitoba, Canada. Dr. Yasser will talk about basic hemodynamic physiology. Most welcome, Dr. Yasser.
Thank you very much. Thank you, the organizers, for the wonderful organization of the workshops. So the first presentation is different from the one that you have in the schedule, and I will tell you why. Based on my impression from the discussions for the last few days, I thought we have to start the first presentation in the workshop about the basic hemodynamics physiology. Okay, so we need to understand the basics of blood pressure assessment. What does the systolic blood pressure mean? What is the systolic blood pressure, and how to evaluate based on the clinical assessment of the blood pressure before understanding the basics of echocardiography and integrating echo, functional echo to the clinical decision making. So the clinical should be on top of everything. We should understand the physiology first. And we'll make it interactive. So I may ask you some questions just to stimulate your mind. You may use your eye character in front of you. Might be simple, just yes or no. So A means yes, D means no. If I ask you any question, or I may ask if you like directly, if you know the answer, you can just raise your hand and let me know. Okay. Maybe if we did the light, a little bit would be more clear. Just like that. Okay, so the main objectives for today to demonstrate physiology of blood flow and vascular resistance. So we'll move away from description of blood pressure as mean blood pressure to understanding what's the blood flow and vascular resistance, and we may get that from the blood, like detailed assessment of the blood pressure. Physiological assessment of abnormal blood pressure changes, and the limitation of relying on blood pressure and the value of integrated DNA to clinical assessment. So when you need to ask help beyond the blood pressure or clinical assessment from someone expert in DNA. So some situations you may rely on blood pressure, and I'll show some case scenarios, and another situation, which is like the most common situation in circulatory shock, you may need to do immediate echocardiography or ask someone expert to do it if you are not very familiar with the technique. And I have clinical categories of circulatory shock. based on the blood pressure. And also the related physiologic based approach. So just go back to the evidence of treating hypertension. There is no any published article clarifying what's the gold standard for blood pressure assessment. So we don't know until now how to treat hypertension based on blood pressure definition. There is no such a clear definition. So I just selected one article here, and this article published by the Research Neonatal Network in US included 16 different units in US, the biggest units. And I'll just read you the conclusion. Antihypotensive therapy administration was not associated with improved hospital outcomes for any of the 15 definitions of low blood pressure. 15 definitions, including mean blood pressure equal to gestational age, blood pressure less than centile, the third centile for the systolic blood pressure less than mean blood pressure less than 30 millimeter mercury, mean blood pressure less than 25 millimeter mercury. So these are just examples of that definitions. So none of the definitions, 15 definitions of low blood pressure investigated, was associated with any of the studied outcomes. Alternative methods of deciding who to treat are needed to maximize patient benefit and minimize harm. So that's why we are here today, to sort out alternative method of treating circulatory shock. So the conclusion, I will just read another conclusion from the study. For the 15 definitions of low blood pressure, investigated therapy was not prescribed for up to 50% of the infant. So they have the definition already in the guidelines, and they did not treat 50% of the patients based on the guidelines that they had. 50%, what does that mean? I'll just translate that to my own interpretation. 50% of infants with low blood pressure, as per the definition that you may have, may improve without treatment. The best common example, treating the blood pressure based on the mean blood pressure equal to gestational age. From the workshop today, we need to go back to our years and move away from that definition. There is no any support from any literature about that. Therapy was administered for up to 41% of infants without low blood pressure. What does that mean? That's my interpretation. If you are solely relying on blood pressure, you may miss almost 50% of cases in early stages of shock, and they develop a reversible shock. You detect them very late, when there is very little chance for them to recover. So it is that time to change your practice from empirical management to more physiologic assessment. Make sense? Okay, so now we'll go to physiology. Blood pressure variable. So the blood pressure is directly proportional, not equal. Direct proportional, because there are other variables not mentioned in the equation. Blood pressure directly proportional to blood flow multiplied by systemic vascular resistance. So the blood pressure, and I mean by the blood pressure here, the mean blood pressure, is reflecting both. So if you have low blood pressure, it might be issue with the blood flow or might be issue with systemic vascular resistance. That's the mean blood pressure. So for example, if you have decreased systemic vascular resistance and significant decrease in systemic vascular resistance and slight increase in cardiac output, that's the most common case scenario when you have septic shock or vasodilator shock. You have significant decrease in systemic vascular resistance and increase in cardiac output, and definitely the blood pressure will be low. Or you may have increased systemic vascular resistance and significant decrease in the cardiac output. In this case, you will have the blood pressure may stay normal because you have balance between both. Increase in resistance and significant drop in the cardiac output and myocardial performance. You have the equation almost of the mean blood pressure, and I will show you case scenarios. If you just look at the mean blood pressure, you will miss the abnormality in the circulation pattern. You may have both of them dropped. That's really severe. When you reach that point, you are almost at the stage of a reversible shock, and significantly you have the mean blood pressure drop. Okay, so we'll start with the basic physiology, and I apologize for being very basic in description for the physiology. I want to be sure that you understand that very well before move on to later more advanced understanding of blood pressure. So we need to understand what is the systolic and what is the diastolic blood pressure. what's meant by systolic, how is the systolic blood pressure created in the circulation, and how is the diastolic blood pressure created. So start with the pump. So the heart needs to create pressure, and this blood pressure starts from the basic blood pressure in the circulation. What's the lowest blood pressure in the circulation? The diastolic blood pressure. So the heart, the left ventricle should contract to create a pressure above the diastolic blood pressure or the basic blood pressure. This pressure should be enough to eject the stroke volume. So from the basic blood pressure, say 30 millimeter mercury, the heart should create another 20 millimeter mercury to eject the stroke volume. Okay? So pumping out the venous return. So the stroke volume should be equal venous return. What the heart is getting should be equal what the heart is pumping out. So that's representing systole. So the systole as a number is representing the pressure needed for the left ventricle to create to overcome the afterload. So overcome the resistance being afterload. So the heart will contract against resistance, so that's afterload on the left ventricle, and this pressure should be enough to pump enough stroke volume. So first question, what's the stroke volume in units? What's the normal stroke volume in units? Who knows the stroke volume in units as a number? Raise your hand. Okay, go. Sorry? Perfect. So it is 1 to 2 ml per beat. If you multiply that by heart rate, you will get the cardiac output, which is the heart rate 120, 150. So the normal cardiac output almost 150 to 300. Very good, thank you. So when the heart contracts, the heart will contract. The larger arteries, including aorta and the branches, they reach elastic fibers. And the elastic fibers is different from muscular media. So they are really rich in muscular media, they are not muscular, they are elastic. So they can yield to the pressure. So the aorta will yield to the pressure and they expand. And with yield, they will absorb some of the pressure. So the number that you see as systolic is not typically the pressure created by the ventricle, because some of the pressure absorbed by the elastic fibers of the aorta and expanded. And with the elastic recoil, there will be another pressure created, which is the diastolic blood pressure. And this the diastolic blood pressure maintained, fixed across the circulation through the muscular media in the arterioles. So the arterioles will maintain the diastolic blood pressure, which might fluctuate up and down according to the tissue needs to maintain systemic vascular resistance normal. So the systemic vascular resistance maintained by the contractile properties of the arterioles, which is different from the elastic fibers in the larger arteries. Okay, so the aorta will expand and recoil, and this recoil will create pressure. Assume the aorta, there is no elastic fibers, and the aorta like pipe, rigid pipe. So what's your expectation for the pressure? So the systole will be very high, extremely high. Instead of 40, 60 will be 200 or more, and the diastolic blood pressure will be 0. Okay? So typically the heart is a source of both systole and diastole indirectly. So systole directly and the diastole indirectly through the expansion. So the aorta absorbed that pressure partially and recoiled to push the blood forward, and the lowest pressure at the end of the recoil is the diastolic blood pressure, which is continued to be maintained through the arterioles and the arteriolar muscular medium. And then we have the capillaries, and the capillaries function as exchange with the tissues fenestrated, and there's some escape of extra fluids which should be drained through lymphatics. And now we have veins very capacitance and working as a reservoir. So most of the blood volume of the body, about 80 to 85% of the blood volume present in the veins or venous compartment, about 10 to 15% in the arterial compartment, about 5% in the capillary compartment. So that's the distribution of the blood in the circulation. Any question so far? Okay, so now we'll make it more clear definition on what's meant by systolic blood pressure and diastolic. Systolic blood pressure is a pressure created by ventricular contractile function to exceed vascular resistance. So there is a difference between vascular resistance and afterload. So the heart to contract against resistance, that's after load. So if there is if the resistance is very high, then after load will be expected to be high, and the heart might fail at the end. So this pressure is needed to push through volume. So typically, the systolic blood pressure means one of the three things. Adequate venous return, because the venous return should be equal to stroke volume, and adequate myocardial performance, because if there is not enough contractile function of the heart cannot pump the stroke volume out. And then what's the systolic blood pressure? The systolic blood pressure is the resistance by contractile property of the arterioles. So typically initiated by the elastic recoil, and then at the end of elastic recoil there is minimum pressure propagated to the arterioles, which is the minimum pressure during the minimum arteriolar or arterial pressure during circulation. And this pressure is reflecting systemic vascular resistance, and it's needed to maintain higher pressure gradient. So that's a function of the resistance to keep the blood propagated to the venous circulation and back to the heart again. So the diastolic blood pressure is reflecting two things: the systemic vascular resistance and overall volume of the body. So there's two volumes now. The small volume, which is short volume, 1 to 2 ml, that's reflected reflected on the systolic blood pressure, and overall volume of the body. So you have severe significant dehydration, you may have, or loss of blood volume, you have low systolic blood pressure. The best example in PDA, when you have significant steal of blood, so the systolic blood pressure is expected to be low because you have significant decrease in the blood volume during the diastole. Mean blood pressure equal 1/3 systolic, 2/3 diastolic, so mix between both. Doesn't give you any like physiologic insight about what's going on in details. And then pulse pressure. So the difference between systolic and diastolic, which is reflected in pulse pressure, might give you a clear idea about the adequacy of systolic blood pressure. So pulse pressure typically about 15 to 20 millimeter mercury, and it is less during the first day of life, during the dental transition. Beyond the first day, it might increase to 20, and increasing with gestational age. Low with poor contractility, low with low preload, and wide with left-right shunt. So wide with left-right shunt through the PDA. Yeah, low diastole, and also a little bit higher systole. So in the PDA with the left-right shunt, according to Starling law, will be volume overload of the left ventricle and more distension of the ventricle, more contraction, pushing the, more contraction means more systole pressure, pushing the blood through the aorta. Aorta will expand more because received more pressure will expand, the elastic recoil will be more. And the expansion of the aorta will be more, and the elastic recoil will be more strong, pushing the blood strong through the shunt. Because of the low pulmonary artery pressure, the shunt will be more and the systole will be dropped. Make sense? Because the pulmonary artery pressure is typically lower than systemic pressure. Unless you have high pulmonary artery pressure, then the shunt will be less. Okay, so if you know this list at the bedside, you know everything about hemodynamics. So if you know the evaluation of hypoxia through this list and the evaluation of hypoxemia through this list, typically if you have it like a checklist and you know everything about this list at the bedside for any sick infant, you know everything about hemodynamics. That's my opinion. So if you know an infant at risk of hypoxia, you know if the infant is hypoxemic or not, go to the other side, and you're looking at this compromised autoregulation, you need to use the technology to evaluate autoregulation, which was one of the presentations today, but we skipped the presentation because now I understand that NEOS is not available very well in Kuwait yet. Hypocapnia, low systemic vascular resistance, hypovolemia, poor maternal performance, high afterload left-right shunt, anemia, and they can at the end they calculate oxygen delivery and have an idea about end-organ performance. So that's everything about hemodynamics. But you need like a really time, this time consuming to evaluate all of these variables at the bedside. So what drugs that do the systemic circulation do we use for systemic circulation support? Vasopressors, inotropin and vasopressor, which is dual drugs, inotropin and vasodilator, and then fluids and steroids. So the list that we are using, and we need to know how to select between these drugs, not just trial and error. Try Valmine, vitamine, epinephrine, and then keep add-on medication without understanding what's going on. So we need to know when to select vasopressor, when to select dual medication, when to select for vasodilator, when to add fluids, and when to consider steroids. So we divided that into categories, 3 main categories. Dr. Ayman, I may exceed the time a little bit today. So like the workshop might be longer than expected. So category number 1, low peripheral vascular resistance. So with the low systemic vascular resistance due to vasodilator shock, what's the expectation to see in the blood pressure? And just focusing in this presentation on the basics of the blood pressure and not too much about echocardiography. And I will leave that to my colleagues, Dr. Evans and Dr. So blood pressure components, if you look at systole, diastole, and mean blood pressure all together. So you have all of these parameters decreased, but with maintained pulse pressure. Maintained pulse pressure means that there is still enough contractility and enough stroke volume, right? But when the diastole drop due to vasodilator shock, the heart does not require to contract in the normal systolic blood pressure, so the pulse pressure will be maintained, but systole will drop. Okay, so the difference between both will be stay the same because the heart doesn't need to create that high pressure. So that's explaining why systolic may drop it as well. But the pulse pressure, that's the value if you're evaluating the pulse pressure at the same time. The pulse pressure will be maintained with the normal. And I will show that on the graph. And when you deal with the blood pressure, we deal with the blood pressure as a trend, not just one number at one time. We'll look at the trend over time. And the trend can be presented as a trend, graph trend, or number trend, or histograms. I will skip the histograms because that might not be available everywhere, or just look at the trend, which I think should be available everywhere. So all associated with ovarian lactic acidosis, so you have significant drop, and the drop we evaluated in retrospectively, and we found that drop of 5 milliliter mercury per hour and continuously drop is significantly associated with development of lactic acidosis. So you don't have to wait until you have significant lactic acidosis, but if you see a continuous drop and the trend is going down, you may intervene early. Like this example here. So can you see the trend of the blood pressure going down? So the trend is available on all of the new renovated monitors. Regardless, GE, Philips, any kind of monitor, you have the blood pressure trend, but you need to know how to check that. Not just look at the blood pressure on time or the bedside nurse writing the number every hour or 2 hours or so. When you look at the blood pressure, you have the trend over time, over maybe about 3 or 4 hours, and you can see the blood pressure trend is going down, but the pulse pressure maintained. So you have 3 lines: diastole, mean blood pressure in the middle, and systole. And the red color is reflecting the pulse pressure. If you move the cursor at any time, you will see the number at the exact time. So there is an option now to move the cursor back and forth, and you can move the time back. How much time back? In monitor, 24 hours. You can go back 24 hours to get the blood pressure trend for the last 24 hours. And if you have central monitor, you can go back up to 1 week back. So, but you don't need that for infant women like having acute circulatory shock. So you have the blood pressure dropping, and if you start from this point until the almost 1 hour or 1.5 hours, so the drop is 5 milliliter mercury per hour. If you put the cursor at the beginning and the cursor at the end, you can calculate the difference. And all through the difference, the blood pressure maintained. So this time we call it category number 1, and that's low systemic vascular resistance because blood pressure maintained. Interventions in this category because we have assumption that pulse pressure normal, so stroke volume should be okay, and venous return, contractility, both should be okay. If you have the ability to do echocardiography and confirm performance failure, that would be perfect. If you don't have And based on this pattern, you can use vasopressor. And vasopressor is not different from vasopressin. Is vasopressin available in Kuwait? Not really? Are you using vasopressin? Really? So not different from vasopressin as a first line or after inadequate response to dopamine. So in our unit, the neonatologist might start with dopamine, okay, 5 mics or so. And 10 mics is that's it, is the end. If there is no improvement, that should be, it means team echo or hemodynamics consultation. And if the pictures like vasodilator shock, just to discontinue dopamine and start vasopressor. So that's a protocol. The neonatologist without TM echo experience means his end is 10 mics, not 20, not 30, not any horrible number. And then at the same time, once you reach 10 mics, you may check cortisol level, because it's very common for circulatory shock, you may have so inadequate suprarenal response to the stress, and you may have relative suprarenal dysfunction, and then hypercortisol might help. So category number 2. Category number 2 is typically similar to systemic hypertension in adult. When you have significant increase in the resistance, which might impact the heart performance. And that's more common in preterm infants, and also more common for post-PD ligation syndrome. Because in this category, you have sudden increase in the resistance after PD ligation, and that might impact the heart performance. Fortunately, we are not doing PD ligation anymore in our unit. But if you are still doing that, you may see that 6 to 12 hours after PD ligation. We call it PD ligation syndrome. So category number 2, high ventricular artery load or high systemic vascular resistance with low cardiac output. You have low to normal systolic blood pressure with high to normal diastolic blood pressure. Typically, you have normal blood pressure in this category. So you have at least normal to high diastole, because sometimes very premature heart may not even tolerate the normal diastolic vascular resistance. Orthogonal marker here is the nerve pulse pressure. And let me show you that. So you have this infant with blood pressure maintained pulse pressure, and at this point here, you can see what happened for diastolic blood pressure suddenly increased, and was continuous narrowing of the pulse pressure. And what's the pulse pressure that you can see here? About 7 millimeter mercury. That's really low. And if you look at the mean blood pressure in this infant, it's actually getting higher. So it was 34 and became 39. This infant deteriorated overnight, and the in-house staff did apply gas, and the lactate started from 5 and in the morning reached 12. And he did not realize what's going on because he missed the pulse pressure, this infant. So he looked at the blood pressure. Blood pressure for him was perfect and even higher than expected. But he missed to look at the pulse pressure, unfortunately. And in the morning, the lactate reached 12. And just, if you keep looking at the mean blood pressure, you'll miss it. So what's the makes sense medication to be used in this category? Vasodilator, very good. So dobutamine, vasodilator was intraocular property, like dobutamine. When we did an echo in this infant, there was also associated pulmonary hypertension. That's why we selected Merinone. So I'll show you the blood pressure after Merinone. So you have the pulse pressure started to widen, and typically the blood pressure dropped. And that's needed because it means that the resistance dropped. So not everything is hypotension. Not everything is just decreasing in blood pressure. You may have infant with even increased pressure with significant shock. So you can see here, I think that's very clear after start of Merinone, that one pulse pressure widened and the lactate came down within hours. So intervention to dobutamine as a first line or after inadequate response to dopamine 5 to 10 mics. Or Merinone, especially if you have echocardiographic evidence of pulmonary hypertension, cortisol level again might be requested, and you may consider hypercortisol in this category. Category number 3. Category number 3, I think now makes sense that you have everything low. That's like the one, the category which is remaining and the most severe and the most difficult to manage. So low all the blood pressure components and nerve pressure, like this. And I will tell you the story of this infant. At 10 o'clock in the morning, the blood pressure was okay. This preterm infant, just to give you the story, preterm infant, 25 weeks, and that's actually the graph that you are using for blood pressure. So you have the highest, which is the 97 centile, and the lowest, 5th centile, and the mean in the middle, for systolic, diastolic, and mean blood pressure. So the blood pressure was okay. That's 25 weeker first day of life. And then at 3 o'clock, this infant developed lactic acidosis. And the bedside nurse, he did not recognize this infant's collapsing. She did not report that the blood pressure is low because she kept looking also at the mean blood pressure. Now we don't have this problem because all of the nurses in our unit now trained how to look at the 3 components. So all of these cases are like history. But now we have a protocol, all of the nurses, they are trained and they pick up any changes in pulse pressure, blood pressure in time, and they report that to the physician. So we don't have such a scenario when you have almost 6 hours of collapse and lactic acidosis here started to be 6. So you have low systole, low diastole, and normal pulse pressure. In this category, you may use, and we use actually epinephrine in this case because like in the category number 3, there's a potential if you use a vasodilator, the blood pressure might drop further. But typically if you use also dobutamine, in this case, that's still acceptable. Okay? But I'm just telling our protocol. Our protocol, if you have all of the hormones are low, we'll use a dual medication. If there is no response from dopamine, and this infant typically responded to 0.05 of epinephrine, and that's it. And then within hours, we went back to 0.03, and 12 hours was off. When you start the right medication right time, you don't have to increase the dose very high, and you don't have to keep the medication for a long time. And again, if you have normal pulse pressure and you don't have echo available to evaluate, conserve fluids first. Because if you don't know about the cerebral venous return, then you cannot assume that the venous return should be is okay in this case. You may prime the heart with fluids first, and then epinephrine, and you can also consider if the soil blood pressure is not very low, you may consider dobutamine in this case. I will just show you an example that you should avoid, because this example might be a disaster, might affect the entire life of any premature infant. So this is a premature infant, 23 weeker, at around 6 hours of age. And you can see the blood pressure, I'm not sure if you can see or not, 31/18, and mean blood pressure 23. So at 6 hours of age, premature 23 weeker. Do you think that this blood pressure is not acceptable for 23 weeker? The diastolic is for 23 weeker is about 15 or 16 is acceptable. So all of these components are acceptable. But one of the fellows, he was not really happy about the blood pressure, and he's concerned to give bolus normal saline. So see what happened after the bolus normal saline. Sudden jump of the blood pressure became almost hypertensive. This is enough to cause IVH grade 4 in an infant at 6 hours of age. Sudden increase in the blood pressure. Just after one bolus normal saline. So one bolus normal saline may give and may affect the entire life of a premature infant. And just after a short period of time, it was just a transient increase in the blood pressure, and the blood pressure came back. When you see the blood pressure plateau, so that's actually the value of looking at the trend. If you see the blood pressure plateau, there is no dropping, as the previous example, plateau. There's no dropping, and there is no lactic acidosis. You cannot rely on the urine output at that stage. You have to just stay tight, and you have that's reasonable blood pressure for very premature infants, 23 weeks. So that's the thing that you need to avoid. That's very kind of harmful intervention. So the arterial blood pressure waveform, just a quick assessment. If you look at the waveform, so the beginning until the peak, and then the beginning of the drop is the systolic time. And then you have a dichotic notch here, which is the beginning, that's aortic closure, and beginning of the diastole. And here you have the end of the diastole. Just that's the evaluation of the arterial waveform. And looking at the arterial waveform, we give you a clue. So what is called the pulse alternance? You remember pulse alternance from the medical school? You can see that actually in the arterial blood pressure monitoring. If you have strong, weak, alternating, this might be reflected for myocardial performance. Remember that because I will show you this now later on. So weaning strategy. Now we started the application, and we need to understand how to wean, because all of these indications, they are very dangerous, and they might affect the neurodevelopment, and all of the published articles about the impact of these medication on neurodevelopment shows bad or negative effect on neurodevelopment. So once you have a reasonable effect, you have to think about weaning, how to wean. And to wean, you should have a strategy to wean. And the strategy typically will be according to the graph of the blood pressure. So we teach our nurses to look at the graph. So you don't have to do everything yourself. Just if you teach the nurses that they understanding the physiology of the blood pressure, once they see the blood pressure between the lowest and mean, you may consider weaning cautiously. But typically when you see the blood pressure between the mean and the highest, then you have to wean. You have to. So you have two options here. Consider cautious gradual weaning. Here you have to start weaning and weaning faster. So here you gradual, the blue line, red line, or the red interval, you have to wean faster. So case number 1, I discussed these cases yesterday. So probably.
But with this slide,
yeah.
when we wean cautiously and when we wean gradually, this
Yeah, again?
okay.
So we have 3 numbers for each parameter of the blood pressure: lowest, mean, and the highest. So if you have the blood pressure between lowest and mean, and not very close to the lowest, you may consider weaning cautiously, and you have to look at the blood pressure systole, diastole, and mean, all of the parameters. Okay? And if you have the blood pressure between mean and the highest, mean that the blood pressure is very adequate, you need to wean and wean faster. And wean faster means you may wean every 15 minutes, 30 minutes maximum. Cautiously, 1 to 2 hours. And cautiously means also the range. If you have the mean of 10, you can wean from 10 to 8 to 6, 4, 3, 0. That's cautious weaning. More aggressive weaning, from 10 you can wean to 5, and then 3, and then 0. Okay? Make sense? Yeah. Faster means like 15 to 30 minutes. Gradual 1 to 2 hours. And each step you need to watch the blood pressure in between. Okay, I think we discussed these cases yesterday. So how many of you did not attend yesterday? So raise your hand. Okay. I'm not sure, for the sake of time, should we repeat the cases or? Yeah, but that might consume more time. So the case number 1, you have a term infant, HIE, 40 weeks, maybe we'll just make it quick. And pulmonary hypertension, INO, lactic acidosis 5. And you have the blood pressure trend is dropping. That's the same example I showed you. So what's the make sense indication here? So you have lactic acidosis is starting to increase, and I have the trend of the blood pressure going down, maintain pulse pressure. And pulmonary hypertension, partial is wanted to nitric oxide. It was 100% if I do drop to 60, and so partial response. What's the make sense indication? Sorry? Merino, you have a normal pulse pressure. So what's the category? So the first question should be, what's the category? Category 1. And the category 1 is low system resistance. Exactly, normal pulse pressure. So assume the normal venous return and normal contractility. And we confirm it by echo. And the echo is even a little bit hyperdynamic contractility. So what the makes sense indication? Vasopressor. And vasopressor, norepinephrine or vasopressin. So I just show you the blood. If you look at the blood pressure trend, you understand that you are going in the right direction. See, just 15 minutes after the start of the indication, the blood pressure normalized. And started like normalize and not keep going up, actually started to be plateau, means that you are perfect. You just improved to the normal range and became plateau. And very low dose of vasopressin. In the morning, the blood pressure dropped again. And dropped again. So what you need to do here, you have the blood pressure trend drop, and that vasopressin is low dose. Increase the dose. Okay, what else? What else? Okay, very good. Before you increase the dose, you have to sort out why this blood pressure decreased, and there is no good explanation. The most common explanation is acidosis. Systemic vascular resistance is very sensitive to acidosis. So think about doing blood gases here, and the CO2 at that time was 80, and pH was 7.01. So what you need to do, don't increase the dose, just improve the acidosis, and within a few hours after increase the ventilatory support, the blood pressure normalized. So think about everything, not just increasing the dose. Okay, another example. So HIE in cooling when the old rear output is 1 ml per kg, no acidosis. An example of harmful intervention. Sorry for mentioning that. But you have a blood pressure here.
What is the category?
Yeah, what's the category first? Sorry? One? What? Who else? That's category 0. There's no category here. That's normal. So you have a plateau blood pressure, plateau. It's no problem. And 47, 31, acceptable pulse pressure, and that's very acceptable for HID or cooling. Okay? Because we expect cooling with, the HID, we should accept lower blood pressure, we should accept lower cardiac output because we are cooling to minimize the harm of liver fusion injury. So that's the aim of cooling.
Usually cause tachycardia and
Exactly, that's also control of that effect of cooling. So in this category, what you should do? Nothing. So unfortunately, one of our colleagues decided to give dopamine 5 mics because he or she was not happy about oral output and also the number. She considered the numbers low for her or he. So for him, sorry. So the dopamine was given here, and what happened for the blood pressure? Became hypertensive. 73 over 50, mean of 60. Okay, from just 5 mics of dopamine, that's harmful. We are cooling to minimize liver fusion injury, and we may create liver fusion injury by ourselves, unfortunately sometimes. Okay, HIE missed be in cooling, and liver and good lactic acidosis increased from 2 to 6 for a few hours. Look at the blood pressure and let me know what's the category here. Sorry? Very good. So what's the category? 1, 2, 3. Category number 2. Very good. You have normal diastole, and low systole. Look at the diastole 41 is low pulse pressure, only 8 mmHg. Look at the mean blood pressure, super normal. If you look at the mean, you will miss it. But this infant was collapsing, and the 3 numbers are almost like 1 line. What's the make sense medication? Yeah, Dubitan. So this infant was given Dubitan for 5 months, and they really improved in short period of time. So lessons from the previous cases. Vasopressin is a good option for cystosis and vasoresistance. Worsening of blood pressure might happen with acidosis. Dubitan is a good option for both systolic blood pressure and now blood pressure. For the light blood pressure, maintain the trend and no acidosis, don't do anything. Okay? Yes. Yeah, very good question. I keep reminding you again, in the 3 categories, if there's no improvement for the first step, increase in the vasopressor or aorta, consider cortisol level. If you don't have cortisol level and the infant requires escalated dose, you can try hypercortisol 2 mg per kg and check the effect of the rat. If the infant responded, there might be suprarenal dysfunction as well. But the best to check the cortisol level before doing that.
At any time after delivery?
Yeah, even premature deliveries, we do that in the first blood work if the infant is very sick at 12 hours of age. The first routine blood work. Add cortisol to that list. Listen. No, before sick. Yeah, sick requiring like very high support as well as the cardiovascular. Not everyone, not a routine. Yeah.
Interesting story here because in our lab, we requested the cortisol level. So our lab director refused to do, he wanted in the early morning. We thought this is For stress baby, not related to...
No stress can be at any time. Yeah.
Keep calling, and our colleague keep calling. We want it now.
Yeah.
And we...
Yeah, for stress infant, it's unrelated to specific
6 a.m.
Like the road.
How many days you have? Next week. Send us
Yeah. Excuse me, please, yes.
If we have the same scenario like Dr. Abdullah still
Yeah.
my previous refused to do the serum cortisol. So after one medication, if I start dopamine or dopamine, whatever, and still not responding,
Yeah.
I should give trial hydrocortisone or I should check another according to me.
You may do the same at the same time, both at the same time. You check the level and you don't have to wait for the results. The infant's really collapsing and sick. Give the first dose and check the effect. So don't wait, you don't have to wait because you may wait for 12 hours and the infant may collapse.
I mean that after one only before starting the second one.
Yes, yeah, after actually the 2 steps. So 5 mics, 10 mics, no response. Then you have to check or give the check and give the first dose. Okay, back to the case scenarios, please. Case scenarios, case number 5. So preterm male infant at 25 weeks, 620 grams. Clinical course was complicated by development of neck stage 3 and required aerial resection with the Eustace. So the infant came from OR, very sick. And for the first 24 hours after OR, post-operatively, stayed anywhere with significant edema and urinary space losses, despite administration of diuretics. So the nephrologist was consulted in this case, and he suggested, or she, to give diuretics in this case. And there is no response to diuretics for the initial few doses. And then you have this image here for the approach chamber view. So I think that it's very clear you have severe underfilled of the heart. So I captured the image at the endosystole. And the endosystole, you should have at least 30 to 40% of the blood volume, of the overall diastolic blood volume remaining, because the ejection fraction is around 65-70%. So you should have a volume remaining at the endosystole. There is nothing left in the heart. So severe underfilling with both ventricles. And that's because of severe third space losses. So what's the intervention in this case? Fluids, yeah. You don't have to fluids. Okay. So what you have to do is the diuretics. So diuretics doesn't make sense to give diuretics in this case. What do you think about the blood? Is the blood pressure drop? What do you think about giving vasopressor? And then fluids. What do you think about inotropes? No, should not be given. Inotropes should not be given anti-heart. Inotropes might improve the systolic performance on the expense of diastolic failure. So might worsen actually the diastolic failure. Should not be given. So just fluids and the fluids. And then you have like some recurrent infusion that's due to this process. And even from the vascular long axis view, you can see like also on the film, you have the septum kissing or touching the ancillary wall. So if you look at the blood pressure, you have low cardiac output. But in this case, you should not give inotropes, okay? You just give fluids. And then you have, look at the mean blood pressure, perfect. And notice the difference between systole and diastole. Now vasopressure because they decrease the stroke volume. In this case, if you haven't done echo, it will be very difficult to detect what's the problem, and you may start to do vitamin in this case, right? Because of the normal suppression, which is really dangerous. So in this case, echo is very helpful to understand the vasophysiology and to continue just to give the fluids. And even this infant might continue to lose the volume in the third space and keep giving fluids. And he may become like balloons from the edema and just give fluids. He may need 2 to 3 days to recover from the capillary leak syndrome post-operatively. During the period, just maintain with fluids, and the infant should recover after that, 2 to 3 days usually. And you may have also the steroids to help with the capillary leak syndrome. So we just sponsor steroids plus fluids, and he recovered in 48 hours. After recovery, if you see that the heart is feeling okay, you may start diuretics at the time to help the body to clear out the edema. Make sense? Any question about this case? Okay, case number 6, weaker 25 weaker, and it will be the last case. Sorry?
In such cases like this, I'm giving fluids and going to the extravascular space.
Yeah.
So, fluids.
No. Yeah. Sorry. I mean, like albumin or something. Like albumin, no, I'm against to give albumin in this case because albumin will be skipped to, will be just working for a short period of time, will be skipped to the third space and will drag on fluids. So we will just give normal saline. Do you agree, guys, about give albumin? Yeah. So I'm against to give albumin in this case, just normal saline.
Plasma.
No, there's not any evidence giving plasma in this case. We never do that. We never do that. And if you do that, you should stop. So later 25 weeks, 12 hours old, so we get a ventilation. I think we discussed this case yesterday. Maybe just a skip because to see time when we, if we have more time, we'll discuss more cases. And then just show. Again, there's the pulses of an S. There is intervals like both ventricular dysfunction, and you can see the pulse is not very stable. So that's pulses also known as alternating weak and strong pulses and very low blood pressure. This is a case we discussed yesterday. Maybe just skip these cases. That's actually the evaluation of our approach. There was not any published research about the muscular trial to evaluate the value of relying on TNECO. If I agree with this, there's no any muscular trial made about doing TNECO versus not doing TNECO and have the outcome at the end. Yeah, there's nothing. So instead of doing that, because we think that it is unethical, because we know the value of doing that at that site, we did retrospective analysis. So what we did in our unit, we evaluated 2 years of applying our program, which is integrated evaluation of hemodynamics, relying on echo and near-infrared spectroscopy and immune techniques, versus the conventional assessment before we started the program. And we evaluated all of the consultations related to PDA, pulmonary hypertension, and shock. For PDA, we decreased the rate of PD ligation from about 10 to 15 cases per year to 1 case every 3 years. And when we decreased the need for nitric oxide in pulmonary hypertension, because there was actually a trend to empiric use of nitric oxide before. So significantly reduced, which is very significant economic impact. And for infants with shock, we evaluated 340 infants over 5 years in 2 epochs. Epoch 1, before the implementation of the program, Epoch 2 after implementation, and what we found significant reduction in the time to clinical recovery. And in another slide, in another analysis, significant reduction in the vasopressor electrolytic score, the magnitude of the medications that we are using. There is less number of cases, but not significant, because the numbers are very small to evaluate this. And we evaluated also the impact of pulse pressure. When you rely on the mean blood pressure, there is no prediction of death or development of hypotensive shock. But pulse pressure was significantly missed. That's why in the first epoch was very significantly correlated with death due to hypotensive shock. So that's echo triage in our unit, which is typically the same in other units in Canada. So we have a neonatal team assess the infant, and that's a triage between us and our colleagues from cardiology. So if the indication is clinically suspected congenital heart disease, even clinically suspected or antenatally diagnosed, because we have very strong antenatal screening program and very, very rare to have a case with congenital heart disease missed from fetal assessment and diagnosed and postnatal. Very few cases every year. So if clinical, even if clinical suspected of cardiomyopathy arrhythmia, then the consultation should be to our colleagues in cardiology. But if the indications for PD hypotensive shock, clinically suspected pulmonary hypertension, cardiovascular compromise due to any reason, pericardial effusion, so that's target natal echocardiography. But the first echo should be evaluated for anatomic screening by one of our colleagues from cardiology. So we have the system, the electronic system to push the study, and we just evaluate from the office for anatomic screening and write report only for the anatomic screening, nothing to mention about function, to avoid any kind of overlapping opinion or, difference in opinion or so. So I'll give you example of, if you have the TN echo revealed undiagnosed congenital heart disease by fetal echo, then you have to refer the case to pediatric cardiology. But if the pediatric cardiology ruled out congenital heart disease and the case revealed to be a functional issue, then the cardiology will refer the case back to us. So that's a way that we would work collegially with our colleagues from cardiology. I'm not sure if you have the system in Australia or UK. So that's actually an example of one of the pediatric echocardiography that's from cardiology or cardiology center. So they call it routine echocardiac anatomy screen. So that's anatomy screen only. Nothing to mention about function. Please refer to TN echo report for any hemodynamic information. So that's kind of respect to the work that we do. So if for any anatomic hemodynamics information, just refer to the other report, which is this report. So that's a TN echo, target natal echo assessment with the calculations needed to assess this infant, which suggested for PD ligation. One of the very few cases that we suggested for PD ligation because of failure of multiple courses of non-cerebral anti-inflammatory drugs. So we have 2 phases of training, 4 to 6 months in echo lab, the cardiology, and the rest of the year, because the training is 1 year fellowship. And the rest of the year should be with the neonatologist expert in hemodynamics. So just to remind you the conclusion, put the rules of evaluation of cardiovascular shock, look at the treatment blood pressure for just one number in one time, systolic diastolic pulse pressure before and after, and during any deterioration. Compare the values to normalize the entire curves of post-cholesterol age. Integrate the impression from systolic diastolic blood pressure with other parameters like renal alcohol acidosis, mean blood pressure, fluid status, hemoglobin, oxygen requirement. Change your formulated recommendation if there is no response. So if you stop medication, you should see the response within 1 hour or 2 hours. If there is no response, don't keep adding medication or increasing the dose without understanding what's going on. So you have to ask for help or change your strategy. But keep adding medication will make the problem even worse. So TN echo is helpful in category 1 and category 2 and 3. If you have normal pressure, you need to do an echo because the problem might be performance, might be venous return. Clinical evaluation is not enough actually to evaluate, especially these 2 categories. Thank you very much. You know, I can give you the slide or I can give you the booklet with the details. Okay? That might be more helpful.
So next staff specialist in digital medicine, we work with Alfred Hospital, Australia, clinical treatment professor, University of Sydney.
Right, okay, thanks very much. There's going to be a little bit of overlap between what Yes has just said and what I'm going to say, because I didn't realise he's going to change the topic. But I'm perhaps taking a bit more of an ultrasound approach to the analysis of the babies. I hear what Yes is saying about blood pressure. I'm not quite as confident as he is in it, and I think it's really important that you actually integrate all the findings, including blood pressure. This is we've been through all this, so I won't go through this again. And this is the importance of this equation. So I think that if you're trying to work out what's going on in an individual baby's hemodynamic, I suppose that the starting point is when do you look? Do you just look when your physiological parameters are abnormal, or do you look prospectively in situations which you know are at high risk of circulatory compromise? I think you have to do both. I think there's actually fairly good evidence that if you wait for blood pressure and other clinical signs, that you will often pick up these problems late, or you'll pick them up after they're well established. And I think in a preterm baby, you can often rescue. In preterm babies, you really want to prevent rather than to actually rescue. But to actually work out what's going on in an individual hemodynamic and looking at central components, I'm only going to be focusing on central components because those are the components that we know most about what our interventions will do things about. You need an impression of cardiac filling. And cardiac filling is difficult, it is subjective. There isn't any validated data between, for example, blood volume and things like end-diastolic diameters and things like that, although logically you would think there would be. But I'll show you anyway that actually if you've got a seriously hypervolemic baby, it's obvious. You need a measure of cardiac function. Ultrasound measurement of cardiac function is extremely complex. And often I think that an impression is just as good as a measurement. You need a measure of systemic blood flow. You need to know how much blood is flowing around the body. And for reasons we talked about in the other talks, I would be using right ventricular output and or suprarenal cava flow. And as a simple measure, mean pulmonary artery velocity is quite a good, quick and easy measure to whether the baby's got low, normal or high systemic blood flow. And you need blood pressure. And blood pressure is really important in this. But you can only interpret blood pressure in the context of actually what's going on with these other things. So this is a very simple breakdown of very similar things to what Yasser was saying. But what I'm really trying to define here is that there's only so many things that can go wrong with the circulation. Now, one of the problems is that those things, I'm going to sort of give you several categories which are similar to the ones that Yasser gave you, and they often occur in overlap. But I think in terms of a model for thinking, it's often quite a good way to think of them as distinct entities and then put them together after the event. So firstly, we have the ductal hemodynamic, and we have the issues of the ductal hemodynamic. Now, obviously, with the ductus, that depends on the direction of shunt. If your shunt is left or right, your problem is one of pulmonary vascular overload. If your shunt is right to left, your problem is that of hypoxemia and blood shunting past the lungs. Paradoxically, you actually, in that situation, often don't have systemic circulatory problems because you have both ventricles pumping systemic blood. You have the hypovolemic hemodynamic, which, as we said, I think several times during these last few days, is actually quite rare. But when it happens, it's serious, and reacting appropriately is life-saving. You have pump failure, or what people might call cardiogenic shock, but in other words, you have intrinsic or extrinsic issues that are actually compromising the function of the pump. You have the vasoconstricted hemodynamic, and these two are clearly very closely related. But actually, one of the reasons for pump failure, and particularly in preterm babies, is that you have a myocardium that is actually not well adapted to high afterloads. Even though the preterm myocardium is actually adapted to the low afterloads of the placental circulation. Postnatally, you actually put the myocardium in much higher afterloads than it's adapted to cope with. So although you could call this vasoconstricted, to a certain extent, these two are very closely related. And then you have the vasodilatory shock where you've just lost vascular tone. And each of these will have different constellations of all the various things that we've talked about. So, if you look at this, this is just a cartoon of what the circulation might look like. I've put so this is the pulmonary circulation, this is the systemic circulation, and you've got basically the two pumps of the right and the left ventricle. Clearly, these two pumps are very closely dependent on each other and very closely related to each other. In any pump, a pump can only pump what it receives. If you see what I mean, if you think about any heart, that's always the case. So in the dominant situation of ductal hemodynamic, which is usually left to right, essentially you've just got a recirculation of blood going back to the lungs. So you actually have pulmonary vascular overload. In the hypovolemic hemodynamic, you're basically losing fluid from the system. The pump depends on enough fluid in the system to be able to allow it to pump blood lungs. And if you consider what you're going to see in that, if you have a typical hypovolemic shock, you're going to see biventricular pore filling in the same way that Yasser showed you. You're going to have low blood pressure, or if they're compensated, the blood pressure may still be all right. You're going to have low systemic blood flow. And you'll usually get a tachycardia. I would say that actually heart rate's often not a very useful marker.
What app shall I open?
In the newborns, but actually in tachycardia, it's quite reliable. Sorry, in hypovolemia, you quite reliably get a chronotropic response. Would be my experience. You've got pump failure, and so if you think about what happens in the context of a pump failure, what you're going to see is biventricular poor function, or you're going to see ventricular poor function, not necessarily biventricular. You're going to have low blood pressure, and you're going to have low systemic blood flow, but the primary thing is going to be the poor function that you're going to see in lungs. In the vasoconstricted hemodynamic, and as I said, that works very closely together with either pump failure or just immaturity of the pump. Essentially what you've got is the pump working against very high resistance and struggling because it's working against high resistance. But because the resistance is high, the blood pressure won't necessarily be low. And so what you get is you may well get low systemic blood flow, but you'll have normal or high blood pressure because your resistance is high. And you may also see biventricular poor function. And then you've got the loss of vascular tone. And I suppose, I mean, you see this in a variety of situations, but where you actually will see it fairly consistently is septic shock. Septic shock is usually a vasodilatory hemodynamic. And linked in with that is obviously distributive shock and microcirculatory shock, which I think we understand an awful lot less about, and we understand even less about what we should do about it. And if you think about that situation, then what you're going to see is low blood pressure, normal or high systemic blood flow, and good biventricular function. These babies are hyperdynamic. So in fact, one of the problems of just reacting to low blood pressure in these babies is that you drive a system that's actually already working very well, and you actually make it even more hyperdynamic. And the final one I'll put in, and just to emphasize the fact, we put in the confounder of the ductus, but the other confounder is the pulmonary circulation. And if you've got low systemic blood flow as a primary thing, you'll usually also have low pulmonary blood flow. But you may have low pulmonary blood flow as a primary phenomenon reflecting on the systemic blood flow. So if you look at a situation where you've got primary PPHN, if your fetal channels are open, then obviously you're going to shunt left to right, and the right ventricle will decompress, and you will actually, you don't, obviously in these fetal channels, you don't necessarily pump the blood directly into the left ventricle, but you're going to pump blood as my marker. It's not going to work. Have I done something wrong here? Oh, there it is. Yeah, okay. So if the fetal channel is closed, you may well have a situation where simply the blood can't get through to the systemic circulation. And you need to remember that PPHN, primary PPHN, has systemic blood flow consequences because quite simply the blood can't actually get through. So to define all these things, you really need to do a sort of global assessment, and certainly in my book that would include doing cardiac ultrasound. So let's look at this in the context of some cases. So this is a baby who was born by von Tooth extraction at 36 weeks. There was prolonged rupture of membranes for 2 weeks. The mother was group B strep positive at 36-week screen. She had a non-reassuring CTG and suspected clinical chorioamnionitis and failure to progress, and that's why she'd gone to a von Tooth extraction. And she'd been given antepartum antibiotics, very intrapartum antibiotics. The Aptos score was 2, 6, and 8. And the baby was born pale and unwell looking at 10 minutes of age. And the baby was taken to the NICU. What do you want to know? What information would you be looking for at this time on this baby? Yeah, saturation was normal. The blood pressure was low. A bit long, yeah. Sorry? Yeah, or even more than that. Yeah. So how about cord gas? Do you know what the baby's condition was at birth? Yeah. Yeah. So you want to know cord gas, but you would also want to know what the blood gas was at birth. Yeah. Anything else you want to know? Anything else you want to know in the history? Yeah, there's certainly a risk of sepsis, isn't there? So you want to know that. Yeah. Anything else you want to know in the history? What's the sort of possibilities here? What are the sort of, I suppose, sepsis would be one. Yeah. Sorry? Blood loss, yeah, certainly. Or asphyxia. Yeah, this is the one who's with a non-reassuring CTG, a pale baby. There's a range of different options here. So that was the cord arterial pH, which is pretty good, pretty cool. Those were the vital signs. Heart rate was 190, mean blood pressure was 28. I think that's systolic and diastolic, I'm afraid. Respiratory rate was 40. Venous blood gas at 50 minutes of age. pH was 7.02. Basic sesamoid speed 15, lactate 8.3. And these were the things I was just fishing for in the history. So there was no intrapartum blood loss. There was no nuchal cord, and the cord had not been separated prior to delivery. And this was the cardiac ultrasound. So what do you think of that? Yeah, this is quite severe underfilling. And this I showed you the other day, that you can see how the walls of the ventricle are sort of touching in both sides of the heart. So, going back to our hemodynamics, what's the hemodynamic here? This is a hypervolemic. Yeah, this is a classic hypervolemic hemodynamic. And so what's the logical treatment? Volume, that's right, yeah. Volume followed up fairly quickly by, how about some blood? And that's what we did. We gave this baby 20 mils per kilo of saline. In fact, we'd already given 20 mils per kilo of saline by the time I did that first cardiac scan, which shows how hypovolemic this baby was. And then we ordered some O-negative blood and we followed it with that. And just to show you the veins, because people often ask me, can you use veins to actually assess volume status? And in fact, this is actually looking at, this is the inferior vena cava. And that's quite small, but if you look at a lot of inferior vena cavas, they look like that. What's more striking in this baby is that actually I'm actually also imaging here the umbilical venous catheter that we put in on an emergency basis. And that's running down the portal venous component of the umbilical venous return, what's called the pars umbilicus. And that would normally be a much bigger vessel than that. Now, that's just an anecdotal observation. But I think that if you rely on the size of the veins, you'll get confused in these situations. And in fact, this baby actually had a combination of two things. The baby had an acute fetal-maternal hemorrhage and also had a subgaleal hemorrhage. And actually, we had diagnosed that clinic there. I didn't tell you that, but that could have been something you want to know on examination. And in fact, this was after we gave another 20 mils per kilo of volume. And this was the subgaleal hemorrhage. So you can see the subgaleal had a depth of about 0.7, about 7 millimeters. So it's quite a significant subgaleal, having heard very early. The baby had normal clotting, and thankfully the subgaleal stopped, and it didn't actually continue to do. So that's the hypovolemic hemodynamic. You do see hypovolemia, significant hypovolemia in other contexts, but the huge majority of cases of severe hypovolemia I've seen have been perinatal blood loss. They've been vasoprevious, they've been acute. I've seen acute twin transfusion ones, acute fetal-maternal transfusions. This is the at-risk period, and I think yesterday when I talked about the the management of HIE. I mentioned the importance of quick exclusions of significant microleukemia. But you usually get clues. I mean, there were a lot of clues here in the clinical pointers. You had a normal cord pH that was getting worse, so this baby was still shocked. You had high heart rate, you had low blood pressure. I didn't give you the hemoglobin, but the hemoglobin was low, because of course. Okay, case number 2. This was a 27-week twin 2, and the twins, they knew they were monozygotic, and they'd been monitoring, actually, interestingly, been monitoring the twin quite closely. But in fact, the baby they were born with undiagnosed at the time polycythemia anemia sequence, TAPS. And so there was an anemic twin, and this was the polycythemic twin. And the baby was intubated, ventilated, was given surfactant. And the hemoglobin was 257 milligrams per litre, and the packed cell volume 72%. The mean blood pressure at 4 hours of age was 45 to 50. Are you worried about this baby hemodynamically at this point? Everything else looked fine. Lactate was all right, blood pressure was good, heart rate was all right. It's on the high side, isn't it? Yeah. Does that worry you? Yeah, it worried me, actually. Yeah. Yeah, the hemoglobin's high. Yeah, you've got polycythemia, so you then get into this thorny question of whether you need to dilute the baby, but we'll come on to that. So I was worried, and I was partly worried because I know these babies are at very high risk. But this was the parasternal long axis view. So I was really, looking at cardiac function here. Any thoughts on cardiac function? Good? Bad or indifferent? Good, I reckon it's pretty good. Yeah, I was pretty happy with that. Yeah, it wasn't too bad, yeah. This was the Ductus Arteriosus. So 4 hours of age, just going again, you've got a pure left to right shunt. That's, you often get a little bit of bidirectionality at this time. There might be a little bit there that we're not seeing on the colour Doppler. That I don't know, I can't remember what the measurement was. I would classify at 4 hours of age. That's really a moderate. It's not a well-constricted duct, but it's not a huge one either. Now this was the right, this is actually the mean pulmonary artery, this is the main pulmonary artery velocity. And they're a little bit on the low side, and when we actually worked out the right ventricular output on this baby, it was 145 mils per kilo per minute. So sort of on the edges, the lower edges of what we would regard as normal. And this was the velocity pattern for the superior vena cava. And when we worked that out, it was 41 mils per kilo, a little bit lower, a bit further below the normal range. So we've got a baby who's got high blood pressure, who's got borderline low systemic blood flow, but is not at this point in time shocked. What's the hemodynamic? It's a vasoconstricted hemodynamic, that's right, it's a vasoconstricted hemodynamic. Do you want to intervene on this baby at the moment? You're going to say vasoconstricted, yeah. Let me start by what's the logical therapy. What I'm going to say is, do you want to intervene in this baby? Yeah, rather than what we want to do you want to do anything? You want to do a partial exchange? I mean, the baby's 4 hours old and 27 weeks gestation. Now, if you, in terms of what we know about what happens to systemic blood flow over the first 24 hours, is this baby likely to get worse or is it likely to get better over the next few hours? In terms of flow, he's going to get worse. You could make a house on the fact he's going to get worse. And there are two things. Firstly, the fact he's premature, but the second thing is that he's a recipient twin. And recipient twins they have this sort of readjusted high peripheral vascular resistance. They're often born hypertrophic hearts and things like that, and it's all to do with the volume load they've been getting in a reset angiotensin renal system. So these babies are actually exquisitely vulnerable to afterload compromise. I've lost several babies like this to afterload compromise. So that would worry me, and this is what I'm trying to get about, understanding not just what's happening at that moment in time in a reactive way, but what is likely to happen to the baby in the future. And generally when you look at what happens in preterm babies, you've got this hypoperfusion, reperfusion cycle that they all do to a greater or lesser degree, but a lot of them don't go low enough to worry about. But that happens, probably they reach the nadir somewhere between 6 and 12 hours of age, and after that time they improve, and the system adapts. So this baby, I would say, is exquisitely vulnerable, although at this moment in time, he's not actually compromised. So, what's the logical therapy? Keep going where you were going. I stopped you because I wanted to ask whether you wanted to intervene.
Nothing.
Say?
Nothing.
Do nothing, but I've just told you it's going to get worse. I think partial exchange would be one thing to do. And actually we did do that. That wasn't the first thing that we did. What was the first thing we did? Yeah. Which inotrope do you want to give? Yeah, I probably wouldn't give them around in a preterm baby just because of the duration of the half-life. I mean, there's a much better drug that's vasodilated and is inotropic. Sorry? What's wrong with debusement? What's wrong with debusement? Yeah, you're not listening to me though. I've just told you this baby's going to get worse. So, do you want to wait for a 27-weeker to go into shock? So we started this baby on debusement. And we started at, I can't remember, 10 or 20 micrograms per kilogram. And we actually also did a dilutional plasma exchange. Now, I'm not quite sure which of those was the most important when you do the sums on what you do to viscosity when you do a plasma exchange. You don't make a dramatic difference. And I think the point at which you do plasma exchanges is a controversial one, but I felt this baby was already showing signs of circulatory compromise, and that we needed to give this baby all the help to.
So the echo reflects what is the explanation why there is no, the ductus is left to right and there is no flow over the LDA. If you review the...
Yeah, what was the low? I think that was probably where I had the setting. I had the setting on the color Doppler, yeah. I don't think this baby had low pulmonary blood flow. This baby would have had normal on high pulmonary blood flow, yeah. But there was a good observation, yeah.
Go from pulmonary blood flow because high resistance, the high risk.
No, I think the baby had normal pulmonary blood flow.
Normal.
But the Doppler, the color Doppler setting was set high because I was looking at the Ductus Arteriosus. So the sensitivity to the lower flow, I mean, it would just be lower flow. Yeah. But this baby is already showing signs of compromise. You've got borderline low systemic blood flow in a baby who's okay at the moment, in who you can anticipate that the baby's going to get worse. And I would say that would be true in many, many preterm babies at this stage.
If I will start with...
So?
So far,
I will not do exchange these days.
But he wasn't hypovolemic.
He's not hyper.
Yeah.
This is not an active because it was initial.
Yeah, but the circulatory effects of it, the effects on the cardiovascular system are chronic and affect postnatal adaptation. And that's the real problem. The recipient twins in twin-twin transfusion are the really vulnerable ones. And they're really vulnerable because they've got this reset renin angiotensin system, and they go into safe bubble level.
But then, like, the real is like the next half an hour, 1 hour, I will instead of starting this.
Yeah, look, you could do that. I mean, to a certain extent, we did do that. I would say this situation was so high risk, I wouldn't wait. Now, if the baby didn't have the complication of being a twin transfusion, then you might want to review. I would probably still treat them. I'd probably still treat them. I mean, in preterm babies, it's always better to prevent than to treat. Always. They're very hard to rescue.
Again,
I've said a lot of controversy here, obviously.
Inotrope also not like prophylactic agent.
Sorry?
If I will start the inotrope itself, I will not start it prophylactically.
No, I'm not arguing you do it prophylactically.
This baby has already good contractility. The main issue for this baby
he's got low systemic blood flow.
Slightly higher pressure.
Sorry, he's got what?
Slightly higher blood pressure.
Yeah.
To reduce vascular resistance.
Yeah.
So why I should give more?
Because he's got low systemic blood flow.
Low systemic blood flow?
Yeah. I mean, that's what you're trying to treat with circulatory support, isn't it? That's what's. Yeah, but the vitamin vasodilates, and that will reduce cardiac load.
Left cardiac output was reduced.
Well, you can't use left cardiac output because you've got Ductus Arteriosus. So that's not, the left output is no longer a measure of
How
systemic
you
blood
can say this low systemic blood flow?
Because I showed you the right ventricular output and the superior vena cava flow.
Well, good.
Yeah.
I will go.
I think I'm going to get back to basis. If you've got shunts in the heart, so if you've got a patent Ductus Arteriosus and you're measuring left ventricular output, you're not measuring systemic blood flow. You're measuring systemic blood flow plus the shunt that's going through the Ductus Arteriosus. So in the transitional circulation, the left ventricular output is not an accurate measure of systemic blood flow. Right ventricular output is better, and right ventricular output is actually a marker of the, it is also systemic blood flow. In you and I, our right and left ventricular outputs will be the same. They're both actually cardiac output. Right ventricular output is better than left, but it's also confounded by atrial shunting. If you've got left or right atrial shunt, that confounds your right ventricular output. So that's why when we studied this, we went back and looked at superior vena cava flow. The right ventricular output is a better measure than left ventricular output. Left ventricular output in the transitional period is pretty much useless measure because you will usually have some shunting at that level. So this is where we would be looking for low systemic blood flow. So the natural history in preterm babies is that their systemic blood flow goes into, over the first 6 to 9 hours, will actually fall away and then will improve by itself. And there are a group of babies who drop really low, and those are the babies who develop intraventricular hemorrhages when they reperfuse. They have high risk of neurodevelopmental outcome. There's a whole wealth of research that relates low systemic blood flow to a range of adverse neonatal outcomes. So I'm worried about this baby getting worse, because this worries me a lot more than it would if this baby had low blood pressure, because the data that links this to adverse outcome is much stronger.
Yeah, so the blood pressure information about the mean blood pressure, which is in this case very very so we cannot rely on feeding.
Yeah.
Because you don't necessarily right blood pressure.
Good.
But they might be convinced more about this is a big issue, so then attention at the same time on cities is really higher than third. So we had the same scenario. We had the same scenario in the struggle about PE. And the local for the hyper also the CPM twins and close to 2 so this
So if you've got a twin transfusion, in a term baby, I wouldn't be concerned. I wouldn't be as concerned.
So that
The prematurity is critical to this case.
I think that's very important.
Yeah.
Typically, we are almost doing the same. I think you remember that study about PLIH.
Yeah, well, that's the same problem after
Yeah,
the compromise, isn't it? Yeah. Yeah.
Until you have to compromise the situation.
Yeah.
Probably stuff that we don't need anymore.
Yeah.
You have to look at it. If you wait 6 to 12 hours after the patient may have significant compensation.
Yeah.
It's almost the same concern.
Yeah.
So I will depend mainly from this case to start to determine on the pulse pressure. If this
Right, but that's different. Doctor events is not really relying on the blood pressure. Different. So that's a different approach. Okay.
Okay. So let's keep going. The other question is whether you closed this ductus. I don't think we did. I think we left this one alone. So this was actually how the baby progressed. In fact, it didn't make a huge difference in this baby. The right ventricular output was 180 mils per kilo at 24 hours, and it normalized by 36 hours of age. This is sort of fairly consistent. I haven't got the data, but I did look again after we started the dibutamine and we'd done the plasma exchange, and we were basically maintaining the systemic blood flow in this baby. And the baby went on to do very well. Okay, another case. This is a baby at 29 weeks gestation who had a severe deterioration on day 7 with what in the end turned out to be pseudomonas sepsis. So this baby was actually in septic shock. He looked terrible capillary refill, pale, the lactate was rising, and the mean blood pressure was 18 millimeters of mercury. What would you expect this baby's cardiac output to be? Low. High, yeah, because he's 7. Anyone think it's low?
Combination shots, not one shot.
Yeah. Could do. It could do. Yeah. So there could be a cardiogenic component. Okay, so this was our assessment. I'm actually now doing left ventricular output, but the ductus was closed, going back to the question when you can use left ventricular output. This baby was 7 days old. And these are the velocities in the aorta. So remember, flow is the product of velocity and cross-sectional area. So high velocity will usually, but not always, particularly if you've got narrowing, will usually mean you've got high flow. So this baby, that would be the normal maximum velocity in the left ventricular output. This baby had a left ventricular output of 600 mils per kilogram. And the heart was hyperdynamic, seriously hyperdynamic. So this baby is pumping around his body, and in fact, interestingly, I've also somewhere got a Doppler of his brain, and he had really high middle and anterior cerebral artery velocities. So this baby's got really low blood pressure, but he's got high systemic blood flow with hyperdynamic heart. What's the hemodynamic? Yeah, this baby's vasodilated. Shock. So vasodilated. So what would be the logical therapy? Vasopressor, yeah. Any preference? Dopamine would work. Yeah, you'd have to push the dose up a little bit. Sorry? Norepinephrine. Yeah. Or vasopressin would be the only thing people would use. There's a reasonable amount of literature on vasopressin in septic shock. I mean, in fact, we had this baby on everything, and I think probably in hindsight that was the wrong thing, because we were actually driving an already overdriven heart. And this baby went on and had a major hemorrhage and we lost the baby. But I think when you look at what we should have done, we probably should have stopped all the untrade and actually just focused on pure vasopressor, like vasopressin or And what's the role of volume expansion in vasodilatory shock? I ask you that because I don't know. What do you think? I mean, the wisdom is, I mean, if you look at pediatric septic guidelines, they tell you to fill the full of volume, don't they? Yeah, I agree. I think it makes sense, but I don't know what people think about that. But you know, you can argue that if you're vasodilated, you have this open vascular space, and so you're going to fill it with volume. I think that's the theory. But it's interesting that even in the pediatric world, they're beginning to question that, aren't they? There was a trial that was done in a developing country where they randomized to high volume or low volume, and the high volume group did worse. So, and yeah, so those are the ones I put down, but I think I would probably go down here to something that probably had less of an inotropic effect. Okay, another case. This was a term baby that represented from home to emergency.
Also by way of the weight gain, also from the feeling of the heart itself and the echo. How is the feeling of the heart?
It was very good. It was hyperdynamic. Yeah.
But good feeling.
Yeah, good feeling. Yeah. So there was really no evidence that it was short volume, but that's a good point. Because that's the other argument, isn't it? That they're third spacing, or they're losing intravascular volume to extravascular volume. Yeah, there was no cardiac evidence of that.
Yeah, but that should not be assumed in all the cases of vascular shock, because sometimes you have significant resistance losses. In this scenario, that we have shown that you may have also empty heart because of the significant loss.
Yeah.
It's not the same in every case, but that's why the ultrasound is very different.
Yeah, that's right. Yeah. I mean, I think that is an important point, that you need to consider the volume status as best you can. Yeah. Okay, so this is a term baby represented from home to emergency on day 14 with sudden onset respiratory distress and pallor. The baby was pale and shut down, and all the pulses were weak, and the blood pressure, mean blood pressure, was 35 millimeters of mercury. The liver was enlarged. The baby had normal cardiac impulse and no murmur. And the baby had compensated metabolic lactic acidosis. What do you think the most likely diagnosis is? Certainly congenital. Yeah. So basically a ductal dependent systemic heart disease. And in fact, that's what we thought. We work in a predominantly, in a lot of services, this would go pediatrics. I work in a predominantly adult hospital that has a big maternity section. So when babies come into, or children come into our emergency department, they're critically ill, we get called. But we went up with the ultrasound machine because that was the clinical diagnosis that this baby had. So 14 days up, this baby had a sort of ductal dependent lesion. They were drawing up across them as we arrived. This was the chest X-ray that they'd already taken. Fairly non-specific, biggish heart, slightly congested looking lung fields. I think there's enough here that would support a ductal dependent That was the long axis view of the personal long axis view. So what do you reckon to that function? Yeah, that's right. The function looks bad, it probably is bad. So this is very poor function. Does that exclude congenital heart disease? No. Yeah, it could be. It certainly could be a decompensated left ventricular outflow still. And the other thing one would have to consider is the impact of acidosis on cardiac function, because acidosis will compromise cardiac function. But we certainly considered all those things. So this was the, I suppose the other thing, it was biventricular poor function. And it's vasodilated, and you can see here the AV valve incompetence in the babies. So this was the velocities for the right ventricular output. We're in the main pulmonary artery here. And again, the right ventricular output was about 140 mils per kilogram per minute. I could have used left ventricular output in this baby because actually the ductus was closed, but we used right. So the baby's got pointers below systemic blood flow. And I think what did I say? The blood pressure was low, it was 35, so a bit on the low side. So what's the hemodynamic here? Pump failure, that's right, yeah. So this is really pump failure, and we've already said this, but what do you need to see to be sure it's pump failure? On ultrasound, what would you need to see? The aortic arch, yeah. And in fact, this was the aortic arch, and we did this fairly quickly, and you can see the colour Doppler signal is pretty low, reflecting the low output, but actually there is no evidence of obstruction to the aortic arch. And the pulmonary valve, the aortic valve was normal. So we actually didn't. So this looked like a primary myocardial problem. And so what would be the logical treatment? Yeah, what's the logical therapy? Yeah, an inotrope was going to help that. And I would probably use one with dilator effects. So we started this baby on dobutamine. We actually moved it to our neonatal unit while we waited for the transport team. And actually we then moved it to one of the children's hospitals because we recognised this was probably a primary cardiac problem. And in fact, the baby turned out to have a viral myocarditis, an acute enteroviral myocarditis. Yeah. And the baby spent about 2 months on ECMO and did get off ECMO, but the heart is still pretty shut now. The baby's now waiting for a heart transplant.
Actually, I have a similar case, and I started treatment as cardiomyopathy or something like that. But after we started treatment and I did the echo, there was coarctation of the aorta. Because initially it's a poor cardiac output, so I found the laminar flow and there's no clear stenosis. But after I started management, one day, and then I repeated the echo, I found clear coarctation of the aorta.
Because you'd improve the output. Coarctation is a nightmare. And it's a dynamic thing as well. That's the other thing about coarctation, is it actually evolves. It's not a static lesion. How am I doing time-wise? Yeah, look, we could have done. I suppose it was just what we were confident with, but I think Laura would have been a reasonable choice in this baby. Yeah. Sorry? The mean was 35. So it wasn't bad blood pressure. It wasn't.
No, it is not worrying in this case, because what happens is a cardiac output problem. So you start building out with the better, lucid problem. And specifically in myocardial diseases, Milrinone is a very good function. And us, as well as the cardiac sector, the first choice in these cases is the Milrinone. Yeah, we can manage it.
Yeah, that was the problem.
I think that's a real concern. But specifically in myocardial diseases, the Milrinone becomes the first line treatment, and if the blood pressure becomes a concern, you can add another item to manage that part. But the lucidity of Milrinone is very helpful in this problem.
Yeah. I mean, we used dobutamine, and we certainly got a good short-term response. Yeah, the baby improved on that. I've got a feeling they might have started milling around at the children's hospital.
Yeah.
But we moved this baby fairly quickly because we recognised it was a primary cardiac problem. Yeah. Have I got time for some more cases? Are we all right? Good. This is a 37-week gestation baby induced for 24 hours of reduced fetal movement. There was blood-stained liquor amniotomy to lower cesarean section. This baby was born in our nearby level 2 hospital. We've got a level 2 hospital about 15 minutes away. The core pH was normal, and the baby developed respiratory distress with an oxygen requirement, so was transferred to us, tertiary neonatal unit. When the baby arrived, it was brought by the transport team. It was being ventilated on pressures of 18 on 5, rate of 40, in 100% oxygen. Saturation was 85 to 90. Carbon dioxide was 32, normally it's mercury. Mean blood pressure was not great, but okay. And that was the chest X-ray. So what do you think the most likely diagnosis would be here? Yeah, a congenital heart disease, yeah. And you have got a, I mean, it's an oligemic lung, but it's a relatively normal lung, isn't it? I mean, there's nothing very remarkable about it. Yeah. What else would be? I mean, it could be cyanotic congenital heart disease. Yeah. And you know, you've got the clues here that the lungs really aren't too bad. You're slightly overventilating on not very high pressures, and we've got a relatively normal X-ray. So on ultrasound, this is what we found, and I mean, I thought this function, the right ventricular function, doesn't look too bad. I wondered if the left was a little bit down, but if you just watch it compared to the right, that right anterior wall is contracting quite a lot better than the left, but that's very subjective and it's very borderline, I think. Hang on, sorry. And in fact, the left ventricular output was again a little bit on the low side. This was the ductus arteriosus. So this is the duct. This is the left pulmonary artery here. And so you've got all blue blood going away from us. These are little vortices. Don't worry about these little red bits here. The little sort of vortices of blood forming within the duct. So you've got a predominantly left. And the other thing, again, in relation to what you showed, Abdullah, is that we can't see any blood at all on colour dot blood in the left pulmonary artery, in either pulmonary artery. You're quite right, in either pulmonary artery. I've lost my pointer again. Oh, there we go. So this was the Doppler in the duct, so it's pure right to left. It's amazing how rarely you see pure right to left ductal shunting. There's almost always a bidirectional component. This was the left pulmonary artery, which confirmed these very low velocities in the left pulmonary artery, suggesting there really wasn't much blood flowing into those lungs. So, what's the hemodynamic? We've got low systemic blood flow. We've got very little blood flowing into the lungs. We've got a pure right to left ductal shunt. Yeah. So this is actually what I would call primary PPHN. So this is a baby in whom the problem is actually in the pulmonary blood vessels. And like a lot of these babies, there was evidence of chronic compromise. Remember, we had reduced fetal movement for 24 hours, and that was the reason that they'd actually delivered the baby. And you find a lot of these babies, you do have evidence of subacute or chronic infusion and compromise. And I wondered if there was some pump failure. So what's the logical treatment here? Yeah. And that's what we gave. And actually, I did give an nitrate because I wasn't totally comfortable with that function. And I think I showed you this the other day, but this is actually the use of left. This is doing very strange things. There we go. The use of the velocity in the left pulmonary artery is a predictor to response to nitrate. So this was a study done some time ago, and basically this was the velocity of the left pulmonary artery, and this was the response to nitric oxide. And you can see the lower the left pulmonary artery velocity, the better the response to nitric. In other words, the more getting the blood and pulmonary vascular resistance is the problem. When you give it later, the more likely you are to improve things. And that's what actually happened in this baby. And this is actually some data that we did very early when we started using nitric oxide, but just to emphasize that actually nitric oxide can be a systemic circulatory support measure. And this was actually before and after nitric oxide left ventricular output. This was not long after we started nitric. This was like an hour after we started nitric. And you can see that in most babies, there's actually an increase. Not every baby, and we didn't specifically select babies who had primary PPHN. But actually, nitric oxide, if you open up the blood flowing through the lungs, you will also open up the systemic circulation. And that was 12 hours later, and we'd overdone it. We'd overdone the artery. And so again, you can overdo it. You can see this heart has become hyperdynamic. The baby's got better, and the heart's become hyperdynamic. And actually, we weaned the arteries very quickly, and the baby's very. And that was the left pulmonary artery Doppler 12 hours later. So the peak velocity was down around here when we started. And you can actually see there's a little bit of left, the shunt, the duct is open, there's still a little bit of shunt there. So you can see how we've improved. Sorry? It improves that. In that study, I didn't look at that. Yeah, I didn't. Yeah, no, I didn't. This was quite a while ago, actually, that we did that study. So we didn't specifically. Yeah. I mean, it might be if you butamine or use Milrinone rather than butamine. Yeah, the baby got better really quickly with nitric oxide, as these babies tend to. Yeah. More cases. Tell me when to start. Yeah, I could go on all day. Okay, that's fine. So let's stop there. Yeah. Okay.
After one, my colleagues, now we continue our fantastic workshop, at the same time, fantastic discussion. Now Dr. Samir will join us. Dr. Samir will talk about renovation hemodynamic in significant PTA. Dr. Samir, Professor of Neonatology at University UK, Senior Consultant Neonatologist, Lead Neonatologist, Hemodynamic Transitional Physiology Program, Cellular Medicine, Doha.
Right, thank you very much, and coming back to Kuwait, please bear with my voice. For some reason, I've been enjoying too much in Kuwait. I've enjoyed the hospitality, the of the Abdullahs, it was very good. So, this is a very simple topic. So, this is a very simple topic, as you know, and the easiest thing to do when you are doing the bedside functional echoes. And the reason is, you put the probe on the chest, you see the red structure, you are so happy because you have seen the duct, right? The problem is that in the last few years, as more and more people are doing it, the diagnosis of PD has increased. And it is now becoming more important that which PDAs we should be treating and which PDAs we should not be treating. So what I will be trying to do is that in the next 20 minutes, 25 minutes, take you through that how do we look at the duct, a very simplistic way which you can follow easily and probably make some informed judgment at the end of it to make sure that we are not overdoing the things as well as we are addressing the ducts appropriately and correlate clinically. Which is important to know about the PDAs because there is a reason why I always believe why God has put the heart and lungs together. And the duct becoming in between the two, it becomes important conduit, and hence the presence of it can affect the pulmonary circulation by increasing the flow to the lungs and make them wet, or it can affect the ductal steel, which means that less flow is going to the body, that is going to cause the systemic effects. So this is a kind of an interplay between the three things, how the heart is functioning, what the duct is doing, is too much blood going to the lungs or it is not going to the body, right? So essentially, if when you have to look at the duct, I would suggest that look at the three parameters which are here. So what are the ductal characteristics? Evaluation of the pulmonary hyperperfusion and evaluation of systemic hyperperfusion. Very simple. So for the ductal characteristics, you need to look at two things. What is the size of the duct and what is the ductal flow, okay? For the pulmonary hyperperfusion, you look at the left heart size and the left heart function. For the systemic hyperperfusion, you look at the post-ductal flow pattern. You could measure it in the aorta or into the intestinal vessels. So look at the ductal characteristics, okay? Measuring the PDA is the important part of it, right? Now, how can we measure the PDA? There are various new machines which have come up now, and with the new machines now, their resolution is better. You can see the structures very clearly, but until recently, the PDAs which were there, they were very difficult to be seen on a 2D echo, and hence the color Doppler was used to identify what is the size of the PDA. So it's still the current practice, majority of the centers is, we look at the color Doppler PDA dimension. But if somebody is measuring the PDA dimension using a 2D echo, it is equally good if the resolution is very good. So essentially what you are trying is measuring the PDA dimension. So here if you look at
that is the pulmonary end of the ductus, because that's the main pulmonary artery, and it is going to go down at this descending aorta, and it meets the descending aorta over here. So where should you measure the PDA dimension, right? The PDA dimension should ideally be measured at the pulmonary end of the ductus, so the point at which it is connecting the main pulmonary artery. And the reason for this is the nomenclature or the practice which is universally agreed. But if the ductus was anywhere narrower, anywhere else apart from the pulmonary end, so if it was a midpoint narrowing, then you would measure the duct at the midpoint. Okay. I have not included the types of PDAs. There are 5 different types of PDA, and it can be straight, it can be tubular, it can be linear, constricted in the middle. So there are various types. And once the commonest ones are more straight or the tubular ones, and they tend to be having a narrowest point towards the pulmonary end. But it is not unusual to find the narrow point away from the pulmonary end, and if it is so, please measure the duct at that particular point. Clearly, it has been shown the right to left duct, you find it is not to be accepted, it's an emergency. Maybe a cyanotic heart disease, which is duct dependent, the right to left flow, or it's a pulmonary hypertension, or veins or TAPVD, which is part of the CHDs. You have to take immediate action. Right to left flow across the duct is an emergency, and I'm sure Dr. Yasser is going to talk more about it in the next talk, which is on pulmonary hypertension. So the right to left flow, essentially, when we look at the Doppler, those who are already doing the echoes, they know that's your line. Anything below the line is a right to left flow. Anything above the line is a left to right flow. So when you are seeing this below the line, this is the right to left flow. So where do you do usually? Now people, they always say that, okay, where do I measure it? The classical is a ductal view. Where is a ductal view? When you do the echo and you put on the short axis, then at the point of the short axis, go a space above and turn the probe into, from your side, it would be a counterclockwise direction so that the pointer is facing up. The pointer is facing up, a space above, you come into the space, and then you are straight off the ductus where you should see the pulmonary side as well as the descending aorta, so that you see the whole ductal course, right? So that is the view to see. But sometimes you see that the baby is ventilated and it is not easy to see. There are various other ways of viewing. You can go supraesternal, you can go subcostal, and you can have the modified views, which if you are interested, then yes, I think it can be discussed in more detail. But routinely, the ductal view is typically left side above one space above the short axis point with the pointer heading 12 o'clock, right? Sometimes it is important when you are looking at the duct, the subcostal view, that is the atrial view, is important because when you start measuring the left atrial aortic root ratio, it is important to know what is there a PDA present, and if so, what is the left to right flow, because it can affect the right ventricular output and how much is going to there. Okay, so in the subcostal view, this is what I have shown you. In the subcostal view, if you are interested, you put the probe in here, right? Your pointer is pointing to the left side. You look up, and when you look up, you turn it so that you get more like a short axis view. So, and that in the short axis view, by turning the probe, you see the red color thing coming into it. It is same like as you see in the parasternal axis. It comes by practice, but again, you are not stuck because majority of the scan can be completed from the subcostal view if you are practicing it, right? Come to it, there's a subcostal view, we have talked about it. Okay, one important thing. Whenever you are measuring the duct using color Doppler, optimizing gain is the important point. And why I say so, if you do not optimize the gain, you can find that the duct is large, small, and you can measure it absolutely wrong. So one is that you see that the flow of the colors, it has to be smooth. So the way we optimize the gain is look at what the velocity of the duct is, you put the scale accordingly. And then we increase the gain so that you see the speckle going around the, getting into the tissue, then come back again. So that you increase the gain. And then you change the scale of the, so that when you change the scale, you see nice smooth contour of the duct, okay? Now, that is important when you measure it, right? So if you look at look at this case, how many of you would say it's a moderate to large, right? How many of you will say it's a moderate to large duct? Just a show of hands. Right, so maybe about 10 people are saying. So I believe others are saying it's a small duct, right? And approximately, if you measure it, it's not been shown here, but you can measure it at a point which is entering the PDA, the pulmonary artery, somewhere about here, and it can be about 2 millimeters, if I may say. Now, if you look at the next case, who will say that it's a moderate to large duct? It's a small duct, right? Now, why I have shown you this is because it's the same baby, which is done only 30 seconds apart, right? And the only difference is the color gain. Right? So that is what the color gain optimization is important, because if it is not appropriate, the same duct you could see as a very small duct or a large duct. And hence, but if once you are doing it, I would suggest always have a comparison also. So when you do the color Doppler, you can have a 2D comparison of that. So always look into the 2D comparator window as how big the duct is it what you are measuring about the same size? 0.1, 0.2 of a millimeter is fine, but anything more than that is not acceptable. So when you are doing the color, try to see that it is appropriately gain optimized and it is more or less matching the 2D. Many people, they measure it with the left pulmonary artery, right? That is easy to do it, and again, it depends on the practice, not necessarily, because what it is that's the left pulmonary artery, and that's the PDA. So if you see that the PDA is more than half of the left pulmonary artery diameter, that is moderately sized duct. But if it is as big as the left pulmonary artery or larger, that is a very large duct, right? So direct comparison to the LPA also gives you some information on this. Right? Okay, now measuring the flow in the PDA. Right to left flow across the PDA, never normal, right? Now when you see a flow in the PDA, you see it in the systole going up and the diastole coming down. And you see a kind of a pattern, right? Now this diastolic point could be right here or it could be right up there. So people, they also describe this as a restrictive duct or an unrestricted duct, okay? Now the easiest way to look at it is, when we look at the various types of the ducts, is what Nick has explained more than 20 years ago, is the various patterns in there. So that's a pure right to left duct, right? Then this is more like a bidirectional duct. This we see as a growing duct. This is a pulsatile duct, and this is as a closing pattern. So why we are talking about various flow patterns? And I think flow done in the first 12, 24, 72 hours or later on, it gives a good insight about the ductal hemodynamics. And the way it is that I'll leave aside the right to left flow, but when you see between these two, these can be transitional circulation, or it can be moving anyway into pulmonary hypertension as the transitional circulation is evolving. So when you see a duct like this, which is having a left to right flow, and then there is a right to left flow which is more than 30%, that is a bidirectional flow. Okay? So remember, in one cycle, if the right to left flow is more than 30% of the cycle, it is not normal. It is coming into a bidirectional flow, and you need to monitor these babies and repeat the scan and evaluate for a high pulmonary vascular resistance. Right? In a one which is below this, you can see the right to left flow is much smaller and it is less than 30%. Now, by the nomenclature, if the right to left flow in the PDA is less than 30% of the time, it is still taken up as it can be treated if your other findings are in favor of treatment or the practice discuss that. If you are looking at the PDA pattern like this, the high systolic and low diastolic, then it is a question of, it is clearly a pulsatile flow duct. So it is no right to left, it is all left to right, but it's a high systolic and low diastolic. Now for this one, I would go back and suggest you that you measure the velocity which is on maximum and the velocity which is minimum, and take the ratio of this, right? This we call as a pulsatility index. If your ratio is 2 or more, that duct is pulsatile. So if you are in doubt, that is the way you can do it. Now I am talking this for the research purposes here, for anyone who is going to do that, because precision of measurement comes in research, but for clinical management, there are a lot of other factors will come there. So to define a duct as a pulsatile, that is what the cutoff we take, systolic to diastolic ratio of 2 or more, right? Now, if you have a pattern, this sawtooth pattern like this, where there is a systolic and the diastolic flow is not too different, this is more like a closing pattern. So if you see a pattern like this, these are the ducts which usually would close. And hence, this is the advantage that when you are doing the flow pattern, you can get a reasonable insight about the hemodynamics of the line, whether it's high pulmonary pressures, it is a PDA which is hemodynamically significant, or it is a duct which is going to close spontaneously. It has been shown that the ductal diameters are quite interesting. So if you have a ductal diameter which is large enough, you see those babies presenting pulmonary hypertension. But the closing pattern ducts will usually be of a smaller size. So again, it gives a guide. A baby with a pulmonary hypertension, once it is resolved, these babies will still have a persistent duct. So what does the duct diameter actually signify? So if you measure a duct, it has essentially, if you measure it correctly, if it is 1.5 or it is 2 or 3, roughly it would mean that the amount of QPQS, amount of blood going to the lungs is almost 1.5 times if it is 1.5 or twice if it is a 2 millimeter. That's a rough guess estimate. So you can see that if the blood is going, if the duct is 1.5 or 2 or 3, that is the amount of blood extra that is going to be in the lungs. So PDA diameter is more or less being taken up as the surrogate for the QPQS ratios as well. So we have talked about the ductal characteristics, that means duct dimension and the flow pattern and what the duct dimension means, correct? Any questions so far? Yeah?
Sometimes in the duct you make the PDE and it's clear that the color is red, this means left to right change. But if you measure the flow velocity, we found sometimes that sometimes on the right side it's more than the left side.
Very good question. So I think that that comes with while you're doing it, right? So what the question is that when you see on the naked eye, you see that the flow is left to right, it is all seen red. But when you do the Doppler, you find almost 30% or 20% or 40% is right to left, right? So these things can happen because the ductal flow is, when you see the eye, you can miss out the segments which are small enough. And one way is to reduce the sweep speed, right? So you have recorded that loop, and then you replay it and decrease the sweep speed. Sweep speed means that speed at which it is working, right? Then you can see that how much it is going, right? And you will be surprised that the naked eye sometimes it misses out, but when you decrease the speed, then you can see, okay, it's the right to left and the left to right, even on the two eye, right? Yeah. Yeah.
What do you prefer to measure the ductal diameter? Color Doppler or 2D?
Yeah.
And how to optimize, if we are going to check by 2D, how to optimize the setting, depth and the gain and
yeah. So the question is about what is the preferable way of doing it. I would say that whatever you are comfortable with, majority of the people, they have been doing over the years the color flow Doppler, and hence they measure on the color flow. As long as it is gain optimized, then the errors are not there. But we tend to measure it both in 2D and the color, so side by side. And then in the cycle we have taken up, so we measure the color and we measure on the 2D because the new machines are quite good for the resolution, and the differences are less than 0.1 or 0.2 millimeters. So with the flow pattern and other parameters, it makes a good judgment, and it also confirms that the color diameter that you are measuring is not too different from the 2D diameter. Okay, I'll just explain to you. The gain optimization for every baby is different because the velocity of the duct is different, right? And hence, what you do is you increase on the color Doppler now, you increase it, right? So turn it on the right side. When you increase it, suddenly you see that it is speckles seen all around it. So that is all seen like speckles. That means you have gone too far. So reduce it so that you don't see any speckle. It stays in the duct or the window. Then you try to change the scale according to the speed of the duct or the velocity of the duct. That would show you that the color is staying in the vessel, right? And it is not bleeding out, and it gives you a good calibration to see that you can measure it appropriately. So what we say is a gain optimization of the color Doppler when you are measuring it using color Doppler in the PDE, right? So when you are, yeah? Yeah, so the question is, how do you measure 30%? If I go back here, so if you look in here, that is the right to left flow, correct? Okay, and that is the left to right flow. So I take the cycle time from the start of the cycle to the end of the cycle and see that what is the left to right flow duration, what is the right to left flow duration. and take the ratio of the right to left flow with the cycle time. So if it is more than 30%, that is clearly on the line of more pulmonary hypertension. Yeah. Yeah. Very good question. So it is very easy to miss when you are, it's a complete right to left flow across the PDA, because in that situation you need to see the three vessels, right? And that is where the ductal view comes in. You need to see the three vessels and then make sure that it is the PDA or that you are seeing it. If you don't have a good window, it is very easy to miss out on the right to left flow. So good point, thank you. Okay, so let's move forward. So we have talked about the ductal dimension and the ductal flow pattern. The second comes in the evaluation of pulmonary hyperperfusion, because that is, now we're starting moving into more effects of it. So what it requires is measuring the left heart size, because if the duct is there, essentially it is going, what Dr. Evans was describing, the ductal flow is left to right. With the left to right flow, it goes to the lungs, it comes back via pulmonary veins, to the left atrium, to the left ventricle, and again it circulates. So it's a circulation happening via the lungs. So when it's happening via the lungs, that means there is too much of blood going to the lungs, and that is what you want to evaluate, that is it affecting the pulmonary side. So to look at that, what you do is, first thing is, you can eyeball while you're starting it. So see, is it showing a pressure on the septum which is bulging into the right ventricular cavity. The same thing you can see on the atrial septum as well. So if it is bulging into the right side, it suggests that there is some dilatation, as if you can see on the naked eye, there is a dilatation of the left side chamber, which is associated with volume overload. You can measure the left ventricular output, and if the left ventricular output is high, you saw the normal range is anywhere about 150 to 300, we take a cutoff about 400. So if your flow is more than 400 ml per kg, that means it's an increased flow, and in the presence of ductus, it suggests there is hyperanaemic circulation. So we will be talking in the stations about how do you measure the left ventricular output, so I leave it for the afternoon. And that's the reason why your LVO is high. You have a ductal left to right flow, increased pulmonary flow, increased left ventricular preload, dilatation, and it is causing left ventricular volume overload there. People also compare the left ventricular end diastolic diameter with the aortic root ratio, and the cutoffs have been set to 2.1. Again, you don't have to do that, but it is, I'm just explaining that there are various ways of assessing if there is a pulmonary hyperperfusion or there is a left ventricular dilatation. Fractional shortening. Usually, this is one of the things which is forgotten. And I will come towards the end to say that when you are doing the ductal assessment, it is very, very important to say, is the heart functioning appropriately? So in a baby where the duct is present and the heart function is compromised, that is more worrying for me than having a large PDA with a normal heart function, right? Diastolic turbulence, it is again, it can be seen in the, while you are doing the pulmonary flow, and this diastolic turbulence, it is because of the ductal flow which hits the pulmonary wall and comes back, and you see that as a diastolic turbulence. So, just if you are seeing, if you are doing a echo for any reason, you see a diastolic turbulence, you didn't suspect a PDA, go and look for a PDA because that is one of the causes for this. In presence of the PDA, and Dr. Evans has very beautifully explained that, the measurement of the right ventricular outflow is very important because that suggests the systemic flow in these babies, not the left ventricular output. Mind you, we always measure the RVO and LVO at the pulmonary wall and the aortic wall, right? Not away from them. So at that point, if you're measuring it and if you find that the right ventricular output is low, that is not normal. That is a worrying thing because this baby needs some help. Left atrium to aortic root ratio, very widely used, and the reason is again, if the left sided is a volume overloaded, you have the left atrium that dilates. Aorta is stiff, it does not dilate. So your reference point is aorta, and you measure your diameter of the left atrium with the aortic root, and that is what it gives the left atrium to aortic root ratio. There has been number of, like not a number of, but people measure it differently. The agreed method is, this is an M-mode measurement across the left atrium going through the aortic roots, and you look at the advancing edge to the posterior wall, and that's the left atrial dimension, but for the aortic, what you are seeing is receding to the receding one here, and that's the aortic root. Some people also measure the aortic root here, but that is a wrong nomenclature, as we measure it, and this is more agreed and universally accepted. So that is the interpreting LAO ratios. Typically, it has been described again by the initial work of Dr. Evans that 1.4 was taken as an upper limit of normal. Anything over 1.4 was increased. But mind you, it is affected by the presence of the patent foramen ovale and how much flow is happening from across the patent foramen ovale, because it can affect your LAO ratios. So in a preterm, that's what the range is, 0.84 to 1.39, and the term is, this is the range, and we have talked about the LA ratios. We have talked about the PFO and the effect on the aortic on this, and some people also look at the mitral valve regurgitation. We don't do it routinely, but it is just time consuming. So third thing to look at is the systemic hypoperfusion, and clearly if the duct is large and there is a diastolic steal, that means the blood is coming back across the ductus. That would mean that there is not enough blood going to the descending aorta and the abdominal arteries. So where you would measure it, you can measure in the descending aorta, or you can measure the flow in the superior mesenteric artery or celiac artery. So that flow, one can measure it, and that allows you to look at the steal. So in the mesenteric artery, this is your descending aorta, your celiac and mesenteric. You put a pulse gate in the superior mesenteric artery. Important is that your pulse gate should be in line with the artery. If it is not in line, you will get a very wrong measurement. And inadvertently you can see as if it is absent within diastole or sometimes reverse, but that is not actual finding. It is because you are missing the signal there. Oh, thank you. Thank you. So the normal superior mesenteric flow, that is what is normal. So you have a normal systole, and the diastole is a forward flow. So that is what is normal. If you have the flow going below the line, that is a reversal of the diastolic flow, right? Not the best of the traces, but what we see, if it is going below the line, that is a diastolic steal, and that is a reversal. So that has been shown to more clearly here. What is the abdominal aorta from our one of the NP presentations, and that's normal flow. Even on looking at, you see it's all red, and that's a normal forward flow. That is forward flow, and there's a reversal of the flow seen over here. There are other modalities which have been used for early prediction of the PDA, and one of them is the EEA ratios across the mitral valve, tissue Dopplers, and speckle tracking. I wouldn't go for the speckle tracking, but just put some eye on the other two parameters. So the EA ratio is when you put the pulse gate across the mitral wall, that's the diastolic flow you are capturing. So the first wave, as was described yesterday, is the E wave, which is the early filling, which should be larger. And the second wave is the A wave, which is atrial contraction. Now, because there is extra volume coming to the left atrium, the atria has to work harder to pump that blood out. That's why your A wave go up. When the A wave go up, your ratio, that is E to A ratio, it goes less than 1, right? So EA ratio of less than 1, it suggests that it's a diastolic volume overload, dependent on the PF also, but this is what is suggesting that the atria is working harder here. So that is what it is showing. There might be flowing here, but that's very clearly shown the E waves and the A waves, as you would see normally. E wave is normally more than A wave, and these are the ones which can be used for the isovolume relaxation time, but leave that aside because we don't use it. Now, what about the TDI? Now, the TDI, when it is done, is for those who would be doing it, it's not very difficult, but tissue Doppler, when you put your pulse gate or tissue Doppler at the septum or the free wall here, what you would see, there is a wave pattern generated, which is a positive wave, which is a S prime, then E wave is the E prime, and the A wave is the A prime, correct? So IVRT is an isovolumetric relaxation time. So after the systole, there is a time it relaxes, okay, and then it would go into the diastole where the E pattern comes in. So the time which is there is an isovolumetric relaxation time. So if it takes longer to relax for the blood to come out, that means there is a volume load and that's because of the PDA. Now coming towards the end, what we need to be checking before reporting is, as it has been mentioned in the cases before, arch of aorta, right ventricular obstruction, pulmonary hypertension, other duct dependent CHPs. Please, always when you are assessing a duct, kindly rule them out because their mishaps do happen and the babies are treated inadvertently, there's a cause for harm. This is what it shows the baby with the coarctation of aorta, and if you see a duct which is out there showing a left-to-right flow across, the right-to-left flow when the baby with the coarctation, you look at the arch and you find there's a turbulence out here, so it's a clear-cut coarctation of aorta. There is another baby which is a pulmonary atresia with a interventricular intact septum. Okay, so here you see a tricuspid regurgitation on the right top window here, right? So there's a tricuspid regurgitation happening here. What you see in this particular view, that's a pulmonary valve, there's the aorta, there's a pulmonary artery. This is a valve which is just not opening. It is the moving heart, but the valve is not opening, right? That was a tricuspid regurgitant jet, okay? And when the so what you see here, there is a PDA which is open, and this PDA is supplying from the descending aorta to the main pulmonary artery. So it's a pulmonary atresia. Because of pulmonary atresia, for the blood to go to the lungs, the duct has to be open. The duct is coming from supplying the blood from descending aorta to the pulmonary artery, and this blood is then going into the right pulmonary artery, and you can say the left pulmonary artery. So large duct with the two vessels going to the lungs. And because of the pulmonary atresia, you are getting a tricuspid regurgitation, which is about generating pressures of 60-70 millimeters of mercury. So if you are not careful enough, very easy in this case, that you think, oh, there's a very large PDA, let me go and treat it. You treat this baby with a cyclooxygenase inhibitor, and the baby is dead. Right? So one has to be careful out there. Baby with pulmonary hypertension, again you'll be hearing more about this, because treating a baby with a clear right to left flow across the PDA is, or more than 30% if it is not a good thing. Hypoplastic left heart syndrome is another case here. You can see a very large duct here, right? Okay, and what is happening is the duct is supplying in presence of this critical CHDs. So if you were to diagnose a duct on a time basis in the first 72 hours, I would say they don't need to look for the two other parameters of pulmonary hyperperfusion or hypoperfusion, because they are not very commonly seen. What you find is that the ductal characteristics have been described. If the duct is large enough, and we take it for the research purpose of 1.5, but clearly if it is 2 millimeters with a pulsatile flow, that duct is being reported as a hemodynamically significant duct in absence of any clinical findings. Because the ducts are usually silent, they don't produce any clinical signs and symptoms, and hence the echo findings, they have to see at least about a couple of days before they present clinically. So in the first 72 hours, usually you can only find out if you decide to treat these babies early on, that you can measure it only on the echo. We are currently doing a large trial in the UK, and this is an early targeted treatment of the PDA, so babies under 28 weeks, all the babies get scanned, and I'm doing this in about 30 centers in the UK, where every baby is scanned, and if they find a duct which is meeting the trial criteria, we take it as more than 1.5 and a pulsatile flow, they are randomized to treatment with ibuprofen or placebo. The sample size in these babies is about 730 babies. We have recruited already 600. So in the next possibly 6 to 8 months, we'll finish the trial. So that will give us an answer whether it is a good approach to treat these babies. It's a large trial that we are doing at the moment. Less than 72 hours, yeah. Less than 28 weeks, less than 72 hours. Yeah. So these things we have talked about. So what is hemodynamic significance? So when we talk about what is hemodynamic significance, it is important that when we are defining to know that which babies are of high risk, right? How do we quantify a hemodynamic significant PDA? It's not a dichotomous entity and it's a physiological continuum, and that has raised the questions whether we should treat the babies with who have a PDA or we should not treat it. Now this is something which has been in the literature and you would have seen these things. On the right is the classification which was by Arvind and Patrick, which was defining the clinical divisions and the clinical and echocardiography and their correlations. Very extensive assessment, but if you are in time, certainly you can look into it and classify. More important is clinical correlation. Important things are, if the baby is over 72 hours, then you are talking about is the baby dependent on the ventilator, or there is refractory hypotension, or there is signs of heart failure. Okay? Oops. If you have in the less than 72 hours, what you find is that on the right top there is a legend which is done by a Phipps work, and all the parameters in the blue box are shown, and that is a kind of a calculation which is used, and you see the ROC curve is quite sensitive on 0.92. So if you are using all these parameters in the first 72 hours, like gestation, diameter, cardiac output, maximum PDA velocity, and the AF prime in the left ventricle, these are the ones which can be used if you have time to do more extensively. But for bedside clinical use, what I described, that is what we have been using through. Now the important slide. The hemodynamic significance of PDA and the assessments, okay? There are three things to look at. First is to look at what is the shunt volume, right? And the shunt volume, look at what is the pulmonary overcirculation or systemic hypoperfusion. The assessment, accurate quantification of the shunt volume, systemic seal, and the pulmonary blood flow. We have talked about this. Second comes is the heart able to adapt it? So it's usually not a problem in the first 72 hours, but later on if the duct is still there, the important bit is the heart able to sustain that PDA. If the heart is able to cope with it, that is good. If the heart is not able to cope with it, it's bad. So for this, you have to assess the systolic and the diastolic function of the heart. And this is what it is important for the clinical management side of things. You also look at the history side. Did the baby receive continual steroids? Is the baby very small? If the baby is 31 weeks, do you really want to treat that baby? No. And majority of the clinicians beyond 28 weeks are now more reluctant to treat the ducts. So gestation, what is the effect on the brain, gut and kidneys? If you have more assessment techniques and monitoring of the babies, these are very important. So having the hemodynamic significance defined is just not on the echo, it is based on the clinical findings and the history as well. So the significance depends on the shunt volume, heart adaptation, and gestation and status. You put them together, it's more about the significance, and it describes the important outcomes. Is there a causal link? Yes, we have to define the significance because of this, and can we modify the course? That is important. And I'll finish up with this because it's very easy to detect a PDA on the echo, but assessing the significance is difficult unless you follow a structured approach, and deciding treatment stays controversial and is dependent on what is your unit practice or what you believe as a duct in causing or not. So thank you very much.
If we are talking about pulmonary hypertension, we are talking about the physiology of hypoxemia. So evaluation of pulmonary hypertension from the neonatologist perspective might be different from non-intensive care physician or non-neonatologist perspective. We are evaluating pulmonary hypertension within the context of hypoxemia. So in the clinical assessment, there is some similarities between pulmonary hypertension and other mechanisms of hypoxemia. At the same time, pulmonary hypertension might be secondary to significant peripheral lung disease or VQ mismatch, and the priority to treat the lung peripheral disease before considering pulmonary vasodilators. So my objective in this session, speaking about the pathophysiology of hypoxemia, management of critically ill infants at risk of hypoxemia with pulmonary hypertension. So we're treating the pulmonary hypertension presented with hypoxemia, because some echocardiographic markers of pulmonary hypertension might be relatively benign during the postnatal transition, and we don't need to do anything. So I will be talking a little bit about the pathophysiology. I'm not sure how many of you attended yesterday, so I will skip some slides. So I'll be talking more about the pulmonary hypertensive markers, a little bit about physiology and more case scenarios. So again, I'm just representing this slide. So you have the list of risk factors for hypoxemia. If you have checklist like this and evaluating the mechanism of hypoxemia and the same time hypoxia, and I think now you understand the difference between both. Evaluating the lung volume, if it is adequate volume and the functional zero capacity or the optimized lung volume, VQ ratio, right left shunt, and I mean intravascular right left shunt, which is extreme diffuse expansion. Hypoventilation, diffusion limitation, when you are thickening the alveolar capillary membrane, which might affect the diffusion of oxygen and will present with hypoxemia. Increased pulmonary vascular resistance, which is typically one of the mechanisms for pulmonary hypertension. High left-right shunt, so just a failure will give you also the same clinical picture of hypoxemia. Pulmonary venous hypertension, which is really very tricky and difficult to be diagnosed by echocardiography, one of the limitations of echocardiography. High mean air pressure compromising hemodynamics. All of these pathophysiologic mechanisms in the list might be presented the same clinical presentation, so you need to understand how to differentiate between them by echo, clinical, and applying different techniques, and I will discuss that during the presentation. Or risk of hypoxia, for giving oxygen to treat the infant presented with hypoxemia, we have to balance at the same time to avoid hypoxia. So Merton definition, just a reminder, I have mentioned that yesterday to remind you. So we need to know what's the hypoxemia, definition of hypoxemia. So from yesterday, how many of you still remember the definition of hypoxemia? Raise your hand. Okay. So there's a definition from the Canadian oxygen trial we used. It is 80% as saturation, or PO2 is a 50 milligram mercury. Hypoxia is different. Hypoxia means that all of the parameters responsible for maintaining normal oxygen level, which is not only saturation, you need the blood flow and hemoglobin at the same time. Typically, in our assessment annual studies and clinical studies, 20 to 40 ml per kg per minute is adequate oxygen level. Hypoxemia, which the saturation of the oxygen saturation is very limited to assess hyperoxemia. Integrating other modality like near-field spectroscopy might add more to the pulse oximetry, and or relying on PaO2, the partial pressure of oxygen. You may have saturation of 99 or 100, but you may have PaO2 of 500, for example, if you get 100% oxygen unnecessary. But if you have saturation above the upper limit of target saturation, if you are targeting 90 to 95, more than 95, if you are requiring oxygen, that should be avoided. PaO2 more than 90 milligram mercury, that also can be a marker if the infant is requiring oxygen. Hyperoxia, if you have high oxygen delivery, and again, if the infant is on oxygen. Okay, quickly revision. Should I revise this slide again, or you are not familiar with it? Okay, because I repeated that many times. Raise your hand if you'd like to repeat the slide again. Okay, so I will just repeat it quickly. So the perfect lung, you have reasonable inflation, perfect inflation, at the same time good blood flow, and the blood coming to the lung, leaving the lung, well oxygenated. So ventilation perfusion is around 0.8 or close to 1. Cardiac output is around 150 to 300, and the same, the tidal volume per or the minute ventilation should be equal to that or close to it, which is around 150 to 200 ml of air coming in and out the lung every minute, the minute ventilation. So there is balance between the ventilation and perfusion. Then if they have the ventilation capacity decreasing, then you have decreased the ratio between ventilation and perfusion. Then you have no ventilation at all and still normal perfusion, and the ratio 0/1. So that's a pure right left shunt, the blood coming into the lung, leaving the lung without any gas exchange. So you have no ventilation, but still the perfusion maintained. So that's pure right perfusion, that's extreme vacuous match. That's common in lung collapse, pneumonia, chronic lung disease, lung congestion. On the other hand, you have maintained ventilation but impaired perfusion, like the case of severe pulmonary hypertension with severe vasoconstriction, massive pulmonary embolism, shock, chronic lung disease with pulmonary hypertension. Then the ratio will be reversed when you have the perfusion decreasing and ventilation maintained until you reach ventilation still maintained, but no perfusion at all, the same like dead space. Again, remind you about this case scenario. If you have severe right left shunt, 50% of them is severe. Like 20-30% circles are severe by pure right left shunt. I'm talking about intrapulmonary right left shunt. So just for simplification, if you have one of the lines totally collapsed, the other line is well ventilated, that's just for simplification to understand the concept. So the blood is passing through the normally ventilated lung and coming out 100% saturation. On the other hand, there is no gas exchange at all. So you have 87% saturation, which cannot be optimized by giving oxygen. If you give oxygen, there's no change. So if you have significant right left shunt, the improvement in saturation might be limited. And you may give 100% oxygen, give less, like 50 or less, saturation will not improve. If you give nitric oxide, there is no any benefit of giving nitric oxide either. So in this case, you need to optimize the ventilation first before considering oxygen, improving oxygenation, or giving more FI2 or starting nitric oxide. Physiology pulmonary hypertension, again, it's equivalent to the systemic blood pressure. The same like pulmonary artery pressure, we have the blood flow multiplied by systemic vascular resistance. So if you have the opposite to systemic pressure, you have increased pulmonary blood pressure, could be due to increased blood flow or increased pulmonary vascular resistance. So in this graph here, you have the 5 typical mechanisms of pulmonary hypertension. But the one that you are typically using in clinical is related to pulmonary hypoxic vasoconstriction, the typical pulmonary hypertension. I went to Turkey one time, and some of the cardiologists they are reporting left-right PDA with pulmonary congestion as pulmonary hypertension associated. So, like our neonatology colleague, they got confused about this description of increased left-right shunt. So they described it as pulmonary hypertension, which is really confusing. But to be honest, from physiology, it might be correct because you have increased the flow and you have compromised the PQ mismatch. And it's still pulmonary hypertension according to the previous equation. So if you're having significantly increases the flow, the blood pressure will increase. But typically in clinical assessment and daily use of pulmonary hypertension, we are considering that as reflecting hypoxic vasoconstriction. Number 2, you have abnormal vasoconstriction due to idiopathic, which is idiopathic as really difficult to be treated, premature closure of Ductus Arteriosus or alveolar capillary dysplasia. This type might not be responding well to nitric oxide. Pulmonary vascular hypoplasia, congestive rheumatic hernia or diabetes also little bit limited response to nitric oxide or pulmonary vasculitis. Excessive blood flow, it is under the same category, but totally different pathophysiology. Here you don't have increased pulmonary vascular resistance, you have the opposite, increased the flow, which might be represented also with hypoxemia, excessive pulmonary blood flow, congenital heart diseases, with left-right shunt or pulmonary venous hypertension would be presented almost typically the same, but management would be a little bit difficult and totally different from increased vascular resistance. So we have typical 4 categories, and the last 2 categories very tricky, and you may need actually the 4 and 5 still should be treated by the pediatric cardiologist, not by the intensivist. So we'll be focusing more in the pulmonary hypertension in this presentation and the other pathophysiology. In this graph showing that at birth, significant improvement in the blood flow, but at the same time drop in the vascular resistance. So it's not a time of birth yet. So collapsing alveoli and little bit some blood flow, almost 10% of the cardiac output, and now significant improvement in the blood flow with improved, after improved ventilation. So drop of the pulmonary arterial pressure, significant improvement in the pulmonary blood flow, and the drop in vascular resistance. That's after. Just to describe the impact of pulmonary, increased pulmonary vascular resistance. Now I'll be focusing on pulmonary vascular resistance on the thermic function in this cartoon. So pulmonary vascular resistance did not drop because it's physiologically high antenatally, because the infant should be exposed to higher oxygen tension of the birth and inflated lung. If this did not happen, then the pulmonary vascular resistance will stay high at the fetal level, and then the pressure will be reflected on the right ventricle. Right ventricle will be still dilated, and PDA will continue to be right direct shunt, as the same like fetal as a fetal channel, and with dilated annulus of the right tricuspid valve, you may have tricuspid regurg, dilated right atrium, and the shunt through the femoral valley will continue to be right to left, and pulmonary venous return will not be adequate because of the pulmonary vascular resistance will continue to be high. So reduced left atrium filling, left ventricle filling, and also the cardiac output below, which will affect at the end the systemic blood flow. And with hypoxemia, we expect also systemic vascular resistance to drop, because hypoxemia is pulmonary vasoconstrictor but systemic vasodilator. And that's explaining why in severe pulmonary hypertension you may have significant drop in blood pressure due to decrease the blood flow and at the same time low systemic vascular resistance. So repeat that again. You have reduced oxygen delivery. So the shunt through the VD will continue to be right to left. Eventually, because of reduced blood flow to the left atrium and left ventricle, the contractility will be impaired. At the same time, there's push from the right ventricle to the left ventricle, which will impact also filling of the left ventricle. So eventually, we have dilated right ventricle, flattening of the septum, or sometimes even pushed from right to left. So the septum goes from right to left. And that can be detected by echocardiography in short axis view, and we'll learn how to do that in our following sessions. With more worsening of pulmonary hypertension, you have bowing of the interventricular septum and more worsening of the left ventricular function. Clinically, if you have infant, just remind you again, if you have infant in the, even in the level 1 ward, and you do two desaturations in 12 hours, or pre and post-mortem saturation more than 5. That's already published to be highly predictive for pulmonary hypertension. And I'm talking about third infant, not return, because that's my health infant that's involved. In term or late return infant, if you have two desaturations or pre and post-mortem saturation difference, you may consider assessment by echocardiography for pulmonary hypertension. So that's a list that we consider, and we made it actually hands-on training today with the group, our group after one, about the markers of pulmonary hypertension. So I considered for simplification dividing pulmonary hypertension assessment into pulmonary hypertension with RV performance, normal RV performance, and pulmonary hypertension with RV dysfunction. Because assessment of right ventricular performance is very crucial and important in any infant pulmonary increased pulmonary vascular resistance. So pulmonary hypertension with normal RV performance, relying on just one marker might be limited. So you may need to see 2 or more markers among this list. So tricuspid regurg Doppler more than 2/3 of the systemic. So tricuspid regurg assessed by continuous Doppler, and we'll show you how to do that. And I have some case scenarios on my simulator. And also, Dr. Gani, you have your echo back system, and you have some cases on the computer, so you also will check some cases with them. IV is flattening for both. So when you have the right ventricle increase, right ventricle pressure increase or pulmonary hypertension higher than equal to systemic, you have flattening of the septum But once you have an infant with increased right ventricular pressure higher than systemic, then the septum will be even worse, compressing the left ventricle. The only limitation of that, when you have infant with systemic hypertension at the same time with pulmonary hypertension. That's one of the limitations of relying on IV flattening. So that's very common to have growing premature infants close to discharge, and some of them they may develop systemic hypertension. Have you seen that? High systemic pressure, which might limit the reliability on the flattening of the septum. So if you have systemic blood pressure high at the same time, then the flattening might not be a reliable sign. The other marker, pulmonary artery acceleration time, ratio to ejection time, and I will show you how to do that in one of the slides. And that has been published to be a reliable sign in chronic pulmonary hypertension, like pulmonary hypertension associated with chronic lung disease. In this category, that's very rare to see typical tricuspid regurg. So we rely mainly on the flattening of the septum and pulmonary artery acceleration time, ratio to ejection time. BDA direction, if it is bidirectional, more than 50% as what has been described in the previous slide by Dr. Samir. Right left shunt, dilated right ventricle, more than left ventricle, and apex mean by the right ventricle is not, that's by high volume. Look at the both ventricles, and you have right ventricle dilated, and the apex mean by the right ventricle, and the septum pushed from right to left. That's also a sign of pulmonary hypertension. This is subjective because you are relying on high volume. LP Doppler less than 0.5, that also has been shown in the presentation of events, more than 0.5 meter per second. And then if you have severe pulmonary hypertension with RV right ventricle affected or RV dysfunction, you may not have enough tricuspid regurg to rely on, because you need strong RV performance to create regurg. So regurg might be suboptimal in this case. So evaluation of RV performance is very crucial in pulmonary hypertension. And more RV contractility can be by icolic. You look at the right ventricle, or right ventricle is not squeezing well. They seem like icolic LV performance, but you need more objective assessment by relying on other parameters. And one of them is TAPSE. And also I will show you how to do TAPSE. Is easy, not very difficult. So TAPSE, tricuspid annular peak systolic excursion. It's a little bit long, but it's kind of easy to measure. You are using M mode, and the M mode just passing through the annulus of the tricuspid band, between the annulus and the free RV wall. And if you have you have waves, and you just evaluate the slope of the wave, and I will show you how to do that. If you have the slope more than 0.7, that's normal, acceptable. Between 0.5 to 0.7 is borderline. Less than 0.5 is very abnormal for any age. And that has been published during the first 3 days by Amish, Patrick, and the Golden Toronto. RV output, if you have right ventricle output, is a 150, which is the cutoff for normal. So we can classify pulmonary hypertension in this category. That's like our classification that we are relying on our center. Mild, 2/3 systemic, moderate close to or equal to systemic, severe exceeding systemic, also a systemic, or any degree of or any of these markers associated with RV dysfunction. RV dysfunction is typically severe pulmonary hypertension. Evaluation of that, that's one of the slides that I borrowed from events software. Okay, it should be a little here. Okay, so we're evaluating the parasternal long axis view and just moving down toward the right hip to get the tricuspid inflow view, and then apply the continuous Doppler across the tricuspid valve and evaluate the peak velocity. And the peak velocity you have tricuspid regurg of 36 or almost 57 millimeter mercury, and correlate this number to the systolic blood pressure. If you see this pattern in infant 1 day old either term or preterm, and is clinically fine and room here, you don't have to do anything. That's just postnatal transition. But if you have this number higher than systemic or close to an infant really symptomatic requiring 60% oxygen, that's a different story. So you have to integrate the markers and the echocardiographic assessment into the clinical assessment and also required. So if you have then the top image, the short axis view, and you have the septum, living between the mitral valve and the iliac muscle. So if the septum is rounded and nice, you have the right ventricle like a crescent, and left ventricle is like rounded. So that's normal rounded IBS. Here we have some flattening, and flattening is more within more clear than accessory. Another example. So in this view, as shown by Gupta, you have the pulmonary artery, and you have the three branches, two typical branches, and the third branch is the PE. And the PE color here is blue, which is reflecting right atrial shunt. And confirmed by Doppler plus or continuous Doppler, and you have pure right atrial shunt. So typically when you have right atrial shunt, it means that the pulmonary artery pressure is higher than the systemic pressure. So in the pulsing short axis view, you have the normal pattern of the intraventricular septum, and you have the flattening of the septum, and you have bowing of the septum from right to left. So you have the right ventricular pressure higher than the left ventricular pressure. So the ratio is now reversed. You have the left ventricle is crescent instead of the right ventricle crescent, and the right ventricle is really very low. So now we'll start to discuss some case scenarios, and we'll, during the hands-on session, we'll practice more about the assessment of TAP C, RV performance, cardiac output. Yeah, go ahead. Sure. You mean postnatally? Yeah, so that's beyond the postnatal transition, because like during the postnatal transition, you may have some tricuspid regurgitation, and again, that should be considered within the clinical context. So if you have an infant in room air and there is not really symptomatic, that would be just reflecting postnatal transition. But you have persistent tricuspid regurgitation with normal systemic blood pressure, because sometimes if you correlate to systemic blood pressure, the infant might be hypotensive, it might not be very reliable to compare to the systemic pressure. You agree, Nick, about that?
Yeah, I mean, I think TI is a great measure. The problem is it's not always there.
Yeah.
And the other problem is you're going to cause hypertension.
So considering postnatal progression is very crucial and important. Also relying on other markers. Like relying on one marker is very limited. So we should have more markers. So 2 or more markers, I think that's reasonable. But relying only on tricuspid regurgitation is really limited. I will give you another case scenario. HIV infants with damaged valves, and you may see actually mitral regurgitation, tricuspid regurgitation very commonly without pulmonary hypertension. And I have seen that, and I have seen some reports from our colleagues reporting that as pulmonary hypertension, and there was no clinical pulmonary hypertension. That's why it's very important to evaluate that within the clinical context.
Yeah, I mean, I think one of the truisms is that all non-invasive measurements, the doctors don't have an error. And the more you can measure the same thing with different methods, the more you've got, if they're consistent with each other, you can be confident or more confident that there is consistent error. So they're all got error.
Yeah.
Can I just add something here? When you explain the presentation, I would suggest that it will be, when you are assessing it cardiographically, if you divide it into 4 segments, assessment of the pulmonary vascular resistance, assessment of the pulmonary artery pressure, the right ventricular function, and the shunts. It helps you in making a very composite assessment for the pulmonary hypertension, because then you can target the therapy appropriately, as was very nice presented by Dr. Yasser, various reasons of the pulmonary hypertension. So using your various assessment tools and dividing into these 4 as what you're assessing is a very, we found it very useful in that assessment.
Very good. Thank you very much. And with the clinical scenarios, maybe you will be there. What?
One more point.
Yes.
In cases where we don't have here, right, possible we still want to get some numbers and I possibly report that's maybe a useful indicator for the diastolic blood pressure in the pulmonary artery, looking at the diastolic gradient when there is an adequate pulmonary regurgitation.
Yeah. So like reliable pulmonary artery calculations as reflective of the systolic pulmonary artery pressure. But what about the systolic pulmonary pressure, which I think might be more important? Because we have seen some people with pulmonary regurg, and like there was not any other significant markers of systolic.
But pulmonary regurg is a measure that can be validated in older subjects. Now, I could only find one study with statistical validation in babies, and actually it wasn't very good. And what you tend to find in pulmonary hypertension is that actually the hypertension, as Yasser says, is systolic hypertension, is not diastolic hypertension. And so I mean, if you don't have any other markers, I mean, you know, one to use is what Yasser was saying, which is the bowing of the septum, but that's qualitative really rather than quantitative. But the other one that I use in that situation is the acceleration time in the pulmonary artery. And certainly in high resistance situations that works quite well. So the time to peak velocity right ventricular ejection time ratio, and you can get that in every baby. Did you go to that? I can't remember if you mentioned it. Again, it's a semi-quantitative assessment, but it will give you a reasonable, and you can get it in every baby.
I think that's a good point. And sorry, the estimation of the diastolic and the mean pulmonary artery pressures has been included in the new document which we have published from the European Society about the NBE in pulmonary hypertension. And in absence of the high pulmonary artery pressures, you can get pulmonary regurgitation where it reflects the pulmonary vascular resistance to be more often, and it is quite helpful in the PR is measured, and the end diastolic pressures relate very well with the PRs there.
There is another measurement that might actually change the septal flattening or septal going from right to left into more objective measurement, which is eccentricity index.
It's called the systolic eccentricity index.
Yeah.
So longitudinal dimension versus across. So you take across the left ventricle on the longer axis versus the transverse axis, and it is decreasing less than 1, then it is clearly going towards.
Yeah, it's validated to be, I think, the cut-limit 0.8 or 80%. Less than 80%. So typically, just let me explain that. You measure the eccentricity index. We measured actually systolic and diastolic in 2 phases. So we take the measurement from anterovestibular and transverse. So in the typical normal left ventricle should be equal. The 2 axes should be equal. So the ratio should be 100% or 1. If the ratio should be 1. If you have the septum start to flatten, then the distance between the septum and the free wall will be decreased compared to the transverse axis. So we have the ratio decreasing. Less than 80% ratio is considered as a sign, could be a sign of significant flattening. And we do that systole in the diastole. When you have more reduced the distance between the septum and the free wall, so you have now the ratio is 50% or less than 0.5 ratio. That's making the flattening or bowing of the septum more objective. We call it eccentricity index. Eccentricity index. So let us discuss some case scenarios to make it like more fun, and we'll ask you to interpret. I'm not sure if I discussed this case yesterday or not. But anyway, third baby, born at 41 weeks, 40 grams, and we had this case happen 6 years ago, and it never happened again. So because we have very, very clear guidelines about the limitation of the neonatologist using knit hoops. So as I mentioned yesterday, our guidelines, the neonatologist not performing echo is not allowed to go beyond 10 lines of dopamine. And beyond that, that's your limit. Because we are using these medications very dangerous, and I will show you in this case what might happen when you have significant amount of drugs as a dose and also as a number of medications. You have HIE infant or cooling, and you have very significant acidosis. mechanical ventilation, blood pressure dropped, according to the team, blood pressure dropped. But I will show you the trend. At that time, there is no nice trend that can be shown, so we did the trend on Excel sheet. I asked one of our fellows to do the trend over the 24 hours. At the beginning, the blood pressure was 58 systolic, 38 the mean, and 20 of the systolic. So if you have the blood pressure like that, and the infant showed like lactic acidosis, it started to improve with no urine output at the time. So what would be your treatment? To give inotropic support or not to give anything? So you can use eye clicker. Yes, give A, B, no.
You cannot see the ID number on the switcher. Please press power button for 3 seconds.
So typically this infant was given to vitamin. So do you agree with my colleague? So yes for A, no for B.
Start voting, please.
60 over, 58 over 20, mean of 38. Okay, that's very good. So, okay, so we have 13% of you agreed to give the vitamin, the same like our colleagues. So giving the vitamin started at, I think it started at 10, increased to 12, and then 20. And then they started to see more worsening of lactic acidosis and more sensitive blood pressure. So they added dopamine of 10, increased to 15. And then started to add epinephrine 0.1, 0.2, 1 mic, and reach 1 mic. Is it a big dose? Is it acceptable dose? 1 mic. I need 1 mic of epinephrine, a kg per minute. Acceptable? Yeah. So overall, you have vasoactive inotropic score of 135. 1 mic of epinephrine is equal to 100 mics of dopamine, just to make it easy. Okay, because we are starting at 0.05, which is equal to 5 mics of dopamine. So that's actually horrible combinations. Dopamine to vitamin of 12, 15, and 1 mics. And all of that, hydrocortisone was given, because everything is worsening. Lactic acid started to increase, your urine output now for 2 days. And you have the blood pressure. What you notice here, the blood pressure started to fluctuate and significant narrowing of pulse pressure. At one point, we have seen actually, I was very surprised how this infant survived. There is no difference in systolic and diastolic blood pressure. It's the same number. Systolic and diastolic, same number. And the same like mean blood pressure for sure. Okay, so I got a call at 6 a.m. in the morning from the neonatologist caring for the baby and asking, now I have such kind of high support, the infant is dying. So should I withdraw his care or not? At this point, yes or no? Withdraw his care or continue and ask for help? Okay, so you don't need to use a high clicker. So I said, yeah, please hold on and I'm coming to assess and see what's going on. I think we already did that. Okay, so if I just show you the point chamber view. Okay. So what's your impression about the point chamber view? Yeah, so the image is not very good because the heart is filling is okay and there is good blood volume. The heart will give you a very nice image. That's why the image doesn't look very good because you have only muscle. Can you see any blood inside the heart? And the left ventricle almost nothing. And the right ventricle is a little bit dilated compared to the left ventricle, if you agree with me. This infant was on raw air, 21%. Was on raw air. And in HIE, you have to be very careful relying on FiO2 for one reason. Who was going to tell me the reason? Why you have to be careful relying only on FiO2 in HIE? Sorry, yeah. Because the oxygen extraction is very low. You have an infant on HIE and cooling, so he's not extracting oxygen. So you may have severe pulmonary hypertension in spite of being in own air. So that's the case of this infant. And then the parasternal long axis view, the same, very good filling. This infant was given 20 cc of saline even at this, like at this time. So you have bidirectional. So just skip the slide. So the infant was given the vitamin in a tube. And the effect of any tube, there is positive effect at the lower range dose, decrease myocardial compliance or decrease the diastolic. So when you give the tube, you may improve the performance of the heart systolic performance at the expense of diastolic filling. Especially if you give the in tube, an infant with good myocardial performance. And then when you give more doses, then you increase the inotropic performance, decrease myocardial compliance, reduce diastolic flow for diastolic function with some peripheral vasodilator effect, which is not the case in the low dose of vitamin. Yeah, I will explain it more in this slide. So in this slide, when you give, so that's a Starling curve, the myocardial performance curve. So the contraction compared to the venous curve. So they meet each other in when you have the central pressure is reasonable. So you have reasonable central pressure or atrial pressure, very normal venous return, and normal myocardial performance. But if you give in the tubes, you will increase the cardiac output eventually, but gradually the venous return will be reduced with more adding more in the tubes. So medical recommendations are trying to discontinue all of the in tubes. Do you agree?
Yes.
Anyone against to just to discontinue all of the in tubes? Not at the same time, but just discontinue one by one and give walls of normal saline in between. So discontinue the vitamin first, and then give normal saline. I give 20 cc and I assess that my echo again to check the filling of the heart. And then another 20 cc discontinue the epinephrine and check the filling. At the end, we have given 50 cc per kg for an infant who has been on fluid restriction for 3 days because of the HIV, right?
Yes.
So that's actually like there is no any reason why this infant was underfilling other than bad effect from the troops. There is no any explanation for volume loss. So we use the vasopressin when the blood pressure started to go. Only small dose of vasopressin improves blood pressure within like 1 or 2 hours. We believe that there is some pulmonary vasodilator effect of vasopressin which never been actually documented in the literature, and we published animal studies showing that there is no pulmonary vasodilator effect, but there is a systemic effect from vasopressin that might squeeze the venous compartment and increase the venous return. That's why that might impact the improvement of pulmonary or filling of the heart in case of pulmonary hypertension. Okay, and this is actually what happened after we did our interventions. So the oral medication, very low dose of vasopressin, I continued hydrocortisone, urine output increased at the same day. Lactic acidosis improved in 4 hours, and related 4 hours. And infant is charged alive for them, stable. And I will show you the echo 24 hours after the first one. Just skip this slide. So look at the time and the 28th of April 2014, 29th of April, second day work. Yeah, that should I can show you. Yeah, I'm not sure the other one why not play the video, but I think it's clear that you can see the filling in terms of to be reasonable compared to the first one. So this is from this case, this is systolic pressure with the normal pressures due to pulmonary hypertension. I forget to mention we started this infant at the same time with nitric oxide, which might be also contributed to the improvement. HIE and cooling might develop pulmonary hypertension without increase in FiO2. Conserve both normal saline before start of tube if you don't know about the filling, because of the impact of inner tubes on the diastolic performance. If there is no response from inner tubes, think about low prelude or echo. If you haven't done echo, you should call for someone to do echo. Don't wait long time before trying another strategy. Don't keep just adding medication and we don't know what's going on, because you may just proceed with the more worsening of the case instead of helping the case. So that's animal study that we did at our animal lab in Manitoba. Shamal Akshinamurti, my collaborator, and Ruth Graham, she's the head of anesthesia department, and that's the animal lab. That's echo machine just dedicated for animal studies. We are not using the same machine, and we should not do that. Use a machine for animal and human at the same time. So we have here the linked and connected to anesthesia machine with the ventilation and all of the monitors around. And she's inserting the central lines for arterial and venous line. So what we did in the study, which has been published in the chest journal, we validated use of vasopressin on pulmonary hypertension. We induced pulmonary hypertension piglets. How we induce that? Expose piglets 3 days in an incubator with low oxygen, like 10% FiO2 for 3 days. And they induce pulmonary hypertension compared to control. And we used vasopressin compared to placebo. And there is no any vasodilator, pulmonary vasodilator effect. There is some improvement in some markers and improvement in myocardial thinning, but there is no typical vasodilator effect. And we did actually also in vitro assessment for myocytes. So also the effect of vasopressin on myocytes outside the piglet, outside the body, and there is no any vasodilator effect. Yeah, there's vasopressor in the systemic, but not pulmonary vasodilator effect. Vasopressor, systemic vasopressor. Okay, so this is actually the iconic museum in Winnipeg. If you come to Winnipeg, you should visit the Human Rights Museum. So conclusion from this is pulmonary hypertension should be assessed as a differential pathophysiology of hypoglycemia. All of the other mechanisms of hypoglycemia should be evaluated and treated principally for prostacyclin and glucoside. The management of pulmonary hypertension is preferred to be managed by neonatologists trained in echocardiography. That's where the pledge that we have in our and that's our belief. Thank you very much. So I have another presentation short about case scenarios. So either we can go for lunch and go directly after that to Dr. Abdullah. Directly from lunch to the practice on, or we can discuss some more case scenarios. So what do you think? So A for yes, more case scenarios, no for just hands-on.
You can start voting, use the clicker to vote, A for yes and B for no. You can start voting now.
Yes for more case scenarios, no for hands-on.
A for more scenarios.
So we have a good solution now, because now we have Dr. Evans and Dr. Gupta, they are leading to the airport. So do the hands-on first, and if you'd like to stay for more case scenarios, you can stay. And if you have any other commitments, or if you'd like to catch your flight, you can leave. Okay, make sense? So we'll go for lunch, and we'll come back for hands-on, and then more case scenarios.